Good afternoon, everybody. Sir Rohit, sir, can you hear me, sir?
Yes, Chandramali, I can hear you.
Good afternoon, everybody. Today is the first day of the second session. So today, this time we are dealing with cardiology and also with the liver and GAT. I welcome Dr. Rohit Patnaik, sir, to start the session with the topic of septic cardiomyopathy. So after you, sir.
Thank you, Chandramali. So without wasting much time, so this will be my flow of slides for today. So first I will be telling about introducing you to the concept of septic cardiomyopathy. Second will be the pathophysiology of septic cardiomyopathy. The clinical presentation I will discuss in very brief terms as to how to see and how to diagnose with a even echo machine. What are the various patterns of septic cardiomyopathy that you will see, and what is the management that you have to do in case of septic cardiomyopathy? So first and foremost, what is the concept? So basically, we know that septic cardiomyopathy is a varied definitions it has got. There is no particular formal definition that has been told for septic cardiomyopathy, and even the surviving sepsis guidelines don't define it accurately. So as of now, whatever from studies we have got definitions, it may be defined as a depressed intrinsic contractility and due to sepsis. And you must remember that this depressed intrinsic contractility is in the background of not giving any vasopressor or inotropic agent and then looking for the contractility and seeing that it is depressed. So that is how we sort of keep it very brief in terms of what is the concept of septic cardiomyopathy. And remember, septic cardiomyopathy is always transient. Whenever the sepsis and the source of sepsis gets better, your cardiac dysfunction will also get better. So this is also one of the things that you have to keep in mind. And this prevalence is also because the definition being very varied and broad, the prevalence has been quoted also very differently in all studies. That somewhere some studies tell it at around 10% and some up to 70%. So as of now, this is a concept which is there, which people know that there is this happens, but the definitions are very loose as of now. So more studies are required. This is a potential area of research. So what is the proposed diagnostic criteria though? So is there someone who has at least got and got together and put up something as to how we will diagnose? Yes, Boycer et al. Actually in the Journal of Intensive Medicine 2021 have proposed a diagnostic criteria. And what is that? As I said just in the previous slide, it has to be acute and reversible. Within 7 to 10 days is the time, approx time, when this cardiomyopathy has to get better. The contraction has to get better. Secondly, usually it is seen that it is a global biventricular dysfunction, and usually there is a depression in the contractility or the systolic function which is there. And this happens in both the ventricles. This is the usual pattern that is seen. What about left ventricle? Does it have reduced contractility along with dilatation? Yes. There is also dilatation of the LV, which is also seen in most of the septic cardiomyopathy patients. And if you see here, and one more thing, in this sort of cardiomyopathy, when patient starts developing shock, there will be reduced, diminished responsiveness to fluid resuscitation and also to catecholamines. This is the hallmark of septic cardiomyopathy, that no matter how much of fluids and catecholamines you give, that time you will not be able to produce much of improvement in shock. And that time you have to suspect that this patient might be having septic cardiomyopathy, put in an echo machine and see how is the contractility. And last but not the least, several times patients come with acute coronary syndrome, and we sort of tell that it is due to sepsis and sepsis induced septic cardiomyopathy. Don't do that. Try to eliminate acute coronary syndrome as the etiology. And only after that, once all of these things fall into place, then only you can go ahead and call it as a case of septic cardiomyopathy. So what about the pathophysiology? So it has been extensively researched. There is still a lot of research pending, and several of the molecules which lead to septic cardiomyopathy have not been decoded as of now. So as of now, if you see, usually when sepsis happens, it is due to some microbe which has caused the sepsis. And when this microbe interacts with immune cells or interacts with neutrophils. So these are the two things that the microbe will interact with. And one of the immune cells which it interacts with here releases cytokines and nitric oxide. And what it leads to is, in one mechanism, the immune cells will lead to a reduction in the cardiomyocyte responsiveness. This reduction in the amount of beta receptors, downregulation of the beta receptors, and lead to cardiomyocyte hyporesponsiveness. and at the same time, it will also lead to vasodilation and warm shock. And these all vasodilation and hyperresponsiveness will ultimately lead to hypoperfusion and lead to damaged cells, which might release DAMPs. So these are basically damage associated molecular patterns. And PAMPs are basically pathogen associated molecular patterns. So these two things, these PAMPs, which will interact with the PRRs, that is pathogen related receptors, and release MDFs and NETs. And ultimately, they will lead to a second type of injury, which is the cardiomyocyte injury, which is a direct injury. So the DAMPs, along with the MDFs and NETs, produce a direct cardiomyocyte injury as well. And finally, they lead to endothelial injury. And slowly, the warm shock, which was initially due to the nitric oxide and vasodilation, leads to an endothelial injury. And finally, reduction in the perfusion, which leads to a cold shock and ultimately multi-organ failure. So this is one of the proposed mechanisms and theories behind the behind the development of pathophysiology of this septic cardiomyopathy. Remember, there are still a lot of research areas pending in septic cardiomyopathy. The MDFs which are there, these molecules have not been decoded yet. It is still known that there are molecules which produce this sort of thing, but what are these molecules? What is the characterization? This has not been done yet. But ultimately, this warm shock leads to a cold shock, which is the terminal part of septic shock. So, what is the clinical presentation? So, usually patients who are having septic cardiomyopathy usually will have it at a later stage, not in the initial stage. As I said, LV reduction in the LV contractility and LV dilatation is something that happens in the later stage of sepsis. The initial stage is usually the hyperdynamic phase. This is the hyperdynamic phase where usually patients will not have much of cardiomyopathy. But in the second phase, where there is a cold shock and LV dilatation, that is the time, that is the sort of septic cool extremity phenotype that usually patients will have when they have septic cardiomyopathy. We also discussed a couple of slides ago that fluids might not improve your septic cardiomyopathy much. Even your vasopressors or catecholamine agents might not help to improve much. You might have patients having cardiac arrhythmias developing in a septic patient, and that time also there might be a possibility of septic cardiomyopathy if patients start developing cardiac arrhythmias. And as I said, the vasopressors and fluids might not work much in a patient with septic cardiomyopathy, with depressed LV contractility and LV dilatation. So these are the usual clinical presentations which are there, but again, it will vary from patient to patient. There are a small subset of patients which behave a little differently than this classic phenotypes that we are seeing here in terms of delayed presentation, cool extremities, or cold shock, inability to respond to vasopressors and inotropes. And that phenotype is basically the early phenotype where you have a hyperdynamic LV. Excuse me. So this is basically the diagnosis of septic cardiomyopathy. I've tried to put it in terms of when the problems start happening. So we see here in the initial part of septic cardiomyopathy, you will have a patient who is having a LV, has got a LV systolic dysfunction. So it is just about starting the LV systolic dysfunction, and that is why this is from one of the very nice journals, which is nicely explained about septic cardiomyopathy. If you see here, this is the focus, which is the LV, where there is mild systolic dysfunction and mild dilatation of the LV. So once this starts happening, then the patient starts also developing hyperdynamic function. Several times patients will present in the very early part of sepsis having hyperdynamic functions of the LV. The second type of hyperdynamic LV function which will be there is a LVOT, dynamic LVOT obstruction, which might happen. So this is basically due to the anterior movement of the mitral leaflet touching the septal wall of the LV. So this also might lead to LV, dynamic LVOT obstruction. And gradually, as it worsens further, the patients might also have LV diastolic dysfunction. That is too much of tachycardia, reduced LV filling time, and that's why there is a diastolic dysfunction which might happen. And also, sometimes patients might present with RV dysfunction. If you see here, the RV is sort of dilated here and pushing onto the LV, and this might cause reduced filling of the LV also, and again leading to LV diastolic dysfunction due to RV dysfunction. So these are all the several patterns that you might see on the echo in a case of septic cardiomyopathy. what are the other various diagnostic techniques? Obviously, you can send a troponin I, but that is a very non-specific test. Several times patients with sepsis will have an AKI and troponin I will fail to give you a right idea about whether it was due to the AKI, the tropi has increased, or whether due to the septic cardiomyopathy, the tropi has increased. So other diagnostic techniques apart from the echo has to be used. These include several times seeing for the pressure volume loop analysis. These are advanced techniques. Even the cardiac MRI has been used several times in decoding the septic cardiomyopathy. Cardiac ventriculography with use of radionuclides has also been used. Remember, all these three things which I am telling about, four things, including the spectral tracking. These all things are basically all experimental approaches. This cannot be used at the bedside. But for further analysis and research, the scientists are using all of these techniques and trying to decode how septic cardiomyopathy behaves. One of the other things that you can use though is basically using an invasive arterial blood pressure monitoring and seeing for a ventricular arterial coupling, whether there is good coupling or not. This is one of the things that you can use at the bedside. So what is the management of septic cardiomyopathy? So if you see septic cardiomyopathy, on the x-axis I have written about the severity of clinical presentation. And on the y-axis, there is an increasing intensity of the interventions that you are going to use if your severity increases. So if you see on the x-axis, initially the patient has got only sepsis and starts to develop certain amount of hypotension and septic shock. And as I said, septic cardiomyopathy is at the fag end of the spectrum of septic shock. If you see here, septic shock with septic cardiomyopathy is at the fag end, that is at the severe end of the clinical presentation that the patient comes with. Several times patients might present to you initially with septic cardiomyopathy, but that symbolizes that the patient's severity is much higher. He's had the sepsis gradually developing at home or in the other hospital. And when he's presented to, he has come with the septic shock and septic cardiomyopathy. So this is where your time point where you are going to see this patient. So once the septic shock and septic cardiomyopathy happens, as I said in the echo slide, you will have depressed LV function. You can also have decreased RV function as well. Remember, usually LV function is the first to go and RV function is much later. I also showed it in the echo slides that the RV function is at the almost the end part of the septic cardiomyopathy. That is where the RV function deteriorates. So if you see, as per the severity of clinical presentation, you first and foremost thing that you have to do is to treat the etiology of the sepsis. So if you see, the etiological therapy is in green. So green therapies are the ones which have been proven and strong quality of recommendations have been given. So the etiologic therapy here is the most important. You have to target what is the source of sepsis. Is there source control happening? Are appropriate antibiotics being given? Is is there any occult source of sepsis which has been missed? These are all the various things you have to focus on according to the surviving sepsis guidelines. The etiologic therapy is the most important thing. Once this gets better, as I said, accordingly, the septic cardiomyopathy is reversible in 7 to 10 days if the etiology has been treated. Second and not the least, fluid expansion. We know that SSC guidelines also include fluid expansion. And fluid expansion is also one of the very strong recommendations, even in case of septic cardiomyopathy. But remember, if you see here, fluid expansion lasts only up to this phase where there is just about the start of hypotension. So sepsis with septic shock without septic cardiomyopathy is the sort of patients that I am interested in giving as much fluids as possible. But once my patients start developing a certain amount of septic cardiomyopathy, I will have to become a little more careful. Fluids can be given, but you have to be very guarded and see that there are no signs of fluid overload happening. So this is where is one of my cutoff points for fluid expansion. So these are the only two proven very strong quality recommendations for septic cardiomyopathy. The other things which are also there are the norepinephrine, which is coded in blue, which has got a moderate level of evidence. So this is basically a vasopressor agent with predominant alpha activity and a very mild amount of beta 1 activity. So even in our SSC guidelines, if you see, norepinephrine is a first choice vasopressor agent in case of septic shock. And despite adequate fluid resuscitation, if there is no improvement in the mean arterial pressures, norepinephrine has been told to be advised to be given to patients. So this does have its role, but you have to remember that sometimes patients who have started to develop a certain amount of septic cardiomyopathy, once you give the norepinephrine and you increase the afterload, that is the time when the actual contractility of the heart starts to get unmasked. So patients who might have 60% EF initially without due to the warm shock and the vasodilation which is there, once you start giving norepinephrine, a certain amount of afterload increase happens. And when this afterload increase happens and the heart faces this amount of afterload, the septic cardiomyopathy starts to get unmasked and unraveled. So that is the time point. You also have to be very careful when you start the norepinephrine that there might be severe amount of sudden increase in the requirements of norepinephrine because you added the norepinephrine, the afterload increased, the LV dysfunction started getting unmasked, and you started having worsening shock because of the reduction in the contractility of the LV. So this is one of the things you have to be careful when you start the norepinephrine in patients who have underlying background septic cardiomyopathy. What about the other inotropic agents such as dobutamine and beta blockers? If you see here, beta blockers are coming with a star. So the star is basically the fact that they are contraindicated in patients with LV systolic dysfunction. But however, we have got some recent research telling about the role of beta blockers in septic shock and septic cardiomyopathy. Well, they are talking of a subset of patients who have got tachycardia and patients who are very likely to develop a lot of diastolic dysfunction because of the tachycardia. That is the subgroup of patients where beta blockers are where you might have to fit in the beta blockers, but that also has to be very guarded. Once you've got good control of your heart rate and your tachycardia, these beta blockers have to be weaned out. What about dobutamine? Dobutamine has some role, but again, this is in relation to norepinephrine. Norepinephrine has to be your first line agent. And if your patients are adequately filled and still having persisting low MAP levels despite adequate fluid resuscitation, and your patients have got LV systolic dysfunction, then that is the point of time you might think of giving dobutamine. But you have to remember that dobutamine also increases the myocardial oxygen consumption as well, and that might lead to increasing amounts of tachyarrhythmias also. So that is also one of the things that you have to keep in mind, and you have to keep your safety targets in mind when you are using dobutamine. A good safety target is targeting tachycardia. If it is increasing beyond 100 to 120, you might have to think of switching off your dobutamine and continuing with your norepinephrine and your second line agent, which is probably vasopressin. What about levosimendan? Levosimendan is not proven to be beneficial. So that's why you have kept it in red. We have kept it in red, and that is not to be used in a case of septic myocarditis. Several trials have shown that it is harmful to use levosimendan. And of course, VECMO, when the severity of clinical presentation is increased to a level that none of your routine therapies have helped, and patient has got worsening refractory shock, that is a point of time you can also think of you going for veno-arterial ECMO. Just a little bit more on the vasopressor therapy, which vasopressor inotrope is the most ideal. So these are the various vasopressors and inotropes which have been studied till now. So most importantly, it is the norepinephrine that is the first line vasopressor agent. Even in a case of septic cardiomyopathy, you might have to have some patients who have got severe LV systolic dysfunction without much of tachycardia. That is the group of patients whom you can give a dobutamine. Epinephrine and dopamine are both being lost into oblivion because several trials have shown that the beta 1 activity is much more than the alpha, and that has led to a lot of tachyarrhythmias. And these tachyarrhythmias have led to diastolic dysfunction and ultimately patients having increased mortality. So these are out. Only things that are left with us is norepinephrine and dobutamine. So these are the things we will focus on when we treat our patients with septic cardiomyopathy. Thank you all for your patient listening.
That's a very good lecture, sir, so far. So I request participants to post your queries in the chat box. Sir, Rohit sir, there is a query from my side actually. Can you hear
Yeah,
me, sir?
yeah,
During
I'm
the
already
initial
sure.
during the initial days of my residency, a patient of septic shock has presented from ER, and I have seen the patient was having uh, anterior cusp of mitral valve obstructing the NVOT. I thought that is a patient of hypertrophic obstructive cardiomyopathy. Then the lateral echo is showing that there is no such kind of HOCM or something. Today, as you said, there are all possibilities of the septic shock cardiomyopathy patient presenting with HOCM. That is a point well taken, sir. So
Yeah,
start
Murali,
with
that is very important. Several times, initial part of the septic cardiomyopathy, patients will have a dynamic LVOT outflow obstruction. That is a hyperdynamic circulation which patients will have. They will have a very high heart rate, and sometimes this high heart rate will lead to a anterior motion moving of the leaflet of the mitral valve touching the septal wall of the LV, and that might lead to a dynamic LVOT obstruction. That is actually one of the time points where even your beta blockers might help you out. Okay,
Exactly,
and
sir.
your beta blockers reducing the amount of tachycardia which is there, that will actually help you to improve your cardiac output. And this actually brings us to the fact that how important it is to do a screening echo in your ICU when patients present with shock. And that is
Exactly, sir.
extremely important because you need to profile your LV or your RV and accordingly give your therapy. Because one size will not fit all. You will have patients who are having hyperdynamic LV. You will have some patients who are much presenting little more later with an LV systolic dysfunction.
Exactly, sir.
Okay. So this is the sort of profiling that you'll have to do with your echocardiography machine.
Sure, sir. And the second point, what I want to highlight is you have well quoted about the Levisimenda. Levisimenda has proven in case of cardiogenic shock, sir, not in septic cardiomyopathy. So that is the point well taken, actually. Okay, sir. Thank you. Without delay, I want to introduce Dr. Sanjeev Dar to present the next topic as an assistant professor in Department of Critical Care Medicine, IMS in some hospital, to talk on myocardial infarction. Sanjeev, sir, please share your people.
Is it audible?
Yes, sir. Yes, sir. It's audible,
Malik?
sir. Please carry on, sir. Audible, audible. Welcome, sir.
So after the first topic, that is a nice topic and nice presentation by Dr. Roy. Your second topic of the third day is myocardial infarction. So I'll toss the epidemiology and the clinical picture and diagnosis of acute coronary syndrome, management, how we manage the STEMI and non-STEMI and STEMI, and complications that arises with myocardial infarction. So epidemiology, this is the acute coronary syndrome presents the most common cause of cardiovascular death, and that accounts about 38% of the all cardiovascular death in female patient and 44% in male patients. So acute coronary syndrome that present is a spectrum that starts with unstable angina, the milder variety that may increase gradually. That have with intensity and risk, we classify that as a STEMI or ST elevated infection and non-ST elevated myocardial infection. So I'll go through the clinical picture and ECG and all biomarker later on. So with clinical feature in unstable angina, we'll find these patients may have oligo or asymptomatic, and in STEMI or non-ST elevated myocardial infection, patients sometimes have chest pain or symptoms, and patient may sometimes have a persistent chest pain. But in STEMI, patient may have a persistent chest pain and sometimes with severity that goes with a cardiogenic shock or acute heart failure, and patient may have cardiac arrest. Similar ECG changes in unstable angina, may find a normal ECG, or sometimes we find some ECG changes. But in STEMI, we may find that ST elevation or ST depression or not elevated ST segment. But in ST elevated myocardial infarction, we usually find a ST elevated myocardial infarction, or in severe variety, patient may present with arrhythmia, malignant arrhythmia. Similarly, in unstable angina, we may not find any elevated cardiac biomarkers, but in STEMI and STEMI, we may find some elevated elevation in the cardiac biomarkers. So this spectrum presents from the unstable angina to the ST elevated myocardial infarction. So for diagnosis, we require three things: the clinical feature, what are the ECG changes, and the changes in the cardiac biomarkers. So along with all together with these three, we diagnose the case of acute coronary syndrome. So our post presentation with the acute chest discomfort. So patient usually present with the most acute chest pain, but if a patient presents the acute chest pain, what should be our goal? We should include the diagnosis of or we should focus towards the acute coronary syndrome, and we should rule out other causes of chest pain or non-ischemic chest pain, and we should do this with a rapid diagnosis and evaluation, so that we can conserve some time and give appropriate treatment. So What are the cardiac cause of chest pain? The cardiac cause of chest pain is the myocardial infarction, ischemia or infection, but non-cardiac causes have the aortic dissection that confirmed with the myocardial infarction or pericarditis. Chest pain that arises from the lungs, these are pulmonary embolus or other causes of pulmonary hypertension. From the chest wall, myocardial or pericardial contusion, traumatic valve injury, or aortic injury. Non-cardiac chest pains, like from gastrointestinal, those are the peptic ulcer disease, gastric ulcer, or duodenal ulcer, or musculoskeletal, like a costochondritis. All this can mimic the acute coronary syndrome or myocardial infarction. So, coming to the clinical picture, first one, clinical patient mostly present with the chest pain or sometimes complaints of some pressure on the chest, mid chest. So, this type of pain is the severe, constant type of retrosternal chest pain. Sometimes that spread across the chest and that radiate to the throat or jaw, left ulnar aspect of the arm or interscapular area. That may last more than 20 minutes, and the patient may sometimes have a sweating, nausea, pallor, dyspnea, and anxiety, and sometimes sweating or diaphoresis. Patient may also have syncope, palpitation, dyspnea, or in severe cases, sudden death may happen. So, but in unstable angina, pain have a similar type, but a milder one and waxing waning type. But pain is reproducible, or pain can again aggravate with emotion or exertion. But sometimes may that unstable angina may accompany with the autonomic symptoms also. Sometimes the acute coronary syndrome or myocardial infarction can have some atypical chest pain, like epigastric chest pain that are confined to jaw, wrist, or interscapular area, and those can have a sharp or snapping type instead of some squeezing type, and reproduced by the chest pressure. So we should promptly diagnose the origin of the pain, that is the acute coronary syndrome, and we should rule out other cause of chest pain with a prompt differential diagnosis, or we should rule out the other causes. So this is the clinical feature. Another for the diagnosis, we need the ECG. So in whom we should do the ECG. We usually patient present with chest pain, we usually do the ECG in any patient. And if a patient over the 50 year, if present with a dyspnea, intermittent status, or upper extremity pain, syncope, or weakness, it is mandatory to do an ECG. Or in the patient with over 8 year, patient presenting with abdominal pain and nausea or vomiting, we should not miss to do an ECG. So this is the European Society of Cardiology guideline. When ECG should be done, this 12-lead ECG recording and interpretation is indicated as soon as possible at the point of first medical contact with a maximum target delay of 10 minutes. So we should do ECG as soon as possible or within 10 minutes. ECG monitoring with defibrillator capacity is indicated as soon as possible in patients with suspected ST-elevated myocardial infarction, because this patient sometimes may have a malignant arrhythmia. So defibrillator should be ready by your side, by patient side. The use of additional posterior chest wall lead V7 to V9 in patients with high suspense of posterior MI, or those because of occlusion of circumflex artery should be considered. And the use of additional right prepared lead, the V3R, V4R, are indicated in case of inferior MI or RP infraction. So if we do ECG, really do get every time the ECG positive find new ECG, that may not be mandatory. So we may not find an ECG always, ECG changes always, and that therefore we do a repeat ECG every 15 to 30 minutes for at least 1 hour, so that we don't miss one ECG changes in the ACS. So what is the universal definition of myocardial infarction? The term acute myocardial infarction should be used when there is evidence of myocardial necrosis in a clinical setting that are consistent with the acute myocardial infarction, or those are having typical chest pain. Under this condition, any one of the following criteria may be used for the diagnosis of MI. So detection of a rise under a follow-up cardiac biomarker value, usually troponin, with at least one value above the 99 percentile of the upper limit, and with at least one of the following finding or sign symptoms: the symptoms of ischemia, new or presumed new significant ST segment or T wave changes, or new left bundle branch block, development of pathological Q wave in ECG, or imaging evidence of new loss of a viable myocardium, or any echo finding that suggests of regional or muscle abnormality. And these are the some angiography or autopsy finding that usually we do. So in ECG, what are the diagnosis criteria for ST elevated myocardial infarction? ST elevation in two contiguous, at least two contiguous leads should be there. So in lead V2 to V3 in age group less than 40 years, if it is more than 2.5 millimeter, is it's diagnostic. And in men more than 40 years, if it is more than 2 millimeter, it's a diagnostic. And female more than 1.5 millimeter in V2, V3. These are all with the current 2023 is European Society of Cardiology guideline. And any other lead, if it's more than 1 millimeter, in the absence of left bundle branch block or left ventricular hypertrophy. If ST depression is there in V1 to V3 with or without ST elevation in V7 to V ST elevation in V7 to V9, that indicated posterior circular artery occlusion, posterior coronary occlusion. So ST segment elevation in V3 or V4, that signifies the ongoing right ventricular ischemia. And ST depression more than 1 meter in more than 6 surface leads. Those are the infralateral ST depression with ST elevation in AVR and or V1, that suggests that multiple vessel ischemia or left main coronary artery occlusion. That is an extensive myocardial infection. And patient, this is more diagnostic when patient is having a hemodynamic compromise or instability. So how we diagnose the non-ST elevated ACS? Into analytical, again, to contiguous lead, if a patient have a new horizontal or down sloping of ST depression of more than 0.5 millimeter, ST depression of more than 0.5 millimeter, and the inversion more than 1 millimeter with a prominent R wave or RS ratio more than 1. So these are the ECG changes. How will identify which artery particularly involved or which artery occlusion occur? So in ECG, we choose some particular lead so that we can identify which particular vessel is involved. So in lateral infractions, we usually use the lead 1 and AVL and the V5 to V6 in the chest lead. Similarly, in inferior lead, we use the 2, 3 and AVF. And in the anteroseptal, we use the V1 to V4. So lateral lead, for lateral lead, we use the lead 1 AVL, V5 to V6 for that indicate the occlusion of the circumflex or diagonal artery of the left anterior descending artery. And inferior lead, there are inferior lead or 2, 3 AVF. These are inferior leads that are suggest right coronary artery or the circumflex artery occlusion. And in anterior or septal, those are V1 to V4 leads. This suggests the left anterior descending artery occlusion. So what are the non-ACS condition where the SCT changes we usually find? Elevation without ischemia, usually the pericarditis, myocarditis, and left ventricular hypertrophy, left ventricular aneurysm, hypertrophic cardiomyopathy, hypothermia, ventricular pest rhythm, and left bundle branch block. Similarly, ST depression in without ST depression without ischemia, hypokalemia, digoxin, and again LAD polization, left ventricular hypertrophy, pest rhythm, and left bundle branch block. Again, some T inversion without ischemia, which we are found in patient with a persistent jubilation pattern or Stokes syncope. And these are again myocardial disease, pericarditis, left ventricular hypertrophy, or myocardial contusions. So these are the ECG changes which we have gone through the clinical picture and the ECG changes. And then what are the third thing that parameter we use the cardiac wiper. Cardiac wiper that we usually use the troponin, but other or cardiac wipers are the myoglobin and the CKAP, and LDH we usually don't use. myoglobin is the first to rise and early to go from the serum also. And similarly, top T that rises in 4 to 6 hours, but that stay together up to, about 10 days. Similarly, the CKMB that arises within 2 to 4 hours, arises within 2 to 4 hours, but that goes or becomes normal within 2 days. Sorry, within 60 minutes. So the CKMB that usually arises in 4 to 6 hours, peaks about to 40 to 24 hours, and peak time to normal is the 48 to 70 hours, and then it's subside early. So this usually we use for diagnose case of whether this patient having a reinfection. In reinfection, patient CKMB again arises. So after initial infection, if patient having chest pain, we can do another CKB. If a patient having raised CKB, then we can say that this patient having another infection. But in case we can't say that with a troponin, because troponin once days that stays altogether for 10 days. So we can infection we cannot use for that troponin. Myoglobin you usually don't use, but this can be used along with the troponin to diagnose early case of viral infection. LDS this is a non-specific cardiomyopathy and usually we don't use. So what about the troponin in a patient with internal renal disease? This in internal renal disease, tropi usually elevated, and these are non-eligible. And measuring serial troponin level improves the diagnostic specificity. Particular value is non-significant. Rather, we do a serial test, and if it is rising trend, then we can say this patient having a concomitant micro infection. So tropi or trip with rise at least about 20% after 6 hours is more specific. So what about high sensitivity cardiac troponin? But European Society of Cardiology 2000 current guidelines says these are the more sensitive in comparison to normal troponin. So normal troponin has sensitivity of 20 to 50%, but this has a 50 to 95% sensitivity. So high sensitivity. High sensitivity assay are recommended over the low sensitivity assay, as they have provided the higher diagnostic accuracy at an identical low cost. So this is the ESCC guideline, current guideline about the high sensitivity troponin. It is recommended to measure cardiac troponin with high sensitivity assay immediately after presentation to obtain result within 60 minutes of blood sampling. It is recommended to use ESC algorithm approach with a serial high sensitivity troponin measurement 0 to 1 hour or 0 to 2 hour to rule out or rule in STEMI. Also, additional testing after 3 hours is recommended if past two high troponin measurement of 0 to 1 hour algorithm are inconclusive or alternative diagnosis explaining the condition have been made. So this current guideline have not mentioned about the normal tropi. They have mentioned all the high sensitive cardiac troponin. So how we do risk stratification and rising of the cardiac symptom by the clinical symptom, history and clinical symptom, ECG changes, biomarker changes, and to the echocardiography. So depending on the history, examination, ECG, cardiomyopathy, we categorize this patient high likelihood of and low likelihood. So these are history, patient having a severe chest pain, having high instability. These are the high risk category, and those patients having probable ischemic symptoms in terms of any intermediate likelihood, characteristic or recent continuous, and any chest discovered that is reproducible by palpation. These are the reproducible chest pain. These are the suggestive of a low likelihood of ACS. Similarly, ECG T-wave flattening or inversion less than 1 millimeter in leads with a dominant R wave or normal ECG. These are low likelihood. Again, normal cardiomyopathy suggests of low likelihood. So, we see for acute ACS diagnosis, we do ECG. We accordingly we diagnose the STEMI or NSTEMI, but patient may not have any changes for non-diagnostic ECG. In these patients, we continue with evaluation continue evaluating and treat not on a monitor bed and repeat ECG and biomarker every 6 to 12 hours. And consider always keep in mind an alternate diagnosis. For management, it's time is very important for this patient. So initial management within 10 hours should be we should check for the air breathing circulation and secure and appropriately we give the resuscitation and we take the preliminary history and see for any cardiac cardiac disease, and see whether there is contraindication to thrombolysis, other comorbidities, or renal efficiency, or any bronchial asthma. We do a prompt physical examination to see whether patient is having a or more underage periods or hypotension. So interpret EC 12 ECG immediately within 10 minutes of past medical control, and do one cardiac map as suggested, and oxygen, give supplemental oxygen if the patient. This is again the guideline suggests if the patient is hypoxemic or saturation less than 90 or PaO2 less than millimeter mercury, then only give oxygen. If saturation is more than 90, we should not give oxygen because that increases the mortality. We should get an IV acid and do blood workup, and they take a cardiac biomarker also, and other routine examination, and give aspirin to the patient promptly. Usually, loading dose of 300, we don't have 325 the tablet. We usually give 4 tablets of 75 milligram dose, unless the patient have a contraindication. And nitrates, obsocopitocline, loading dose of 300 milligram. Nitrate we shall give 0.4 milligram. You may need a repeat dose unless the patient is contraindicated. And nitrate should not be given if a patient have received phosphodiuresis inhibitor within 24 hours, or patient having right coronary infraction or alveolar infraction, or patient having a hypotension. Simultaneously, morphine usually give a 5 to 10. This guideline says 5 to 10 milligram per milligram to relieve the chest pain, or a milder tranquilizer can be used. So this is the pathway how you go through go about the patient presenting with ST elevation micro infection. So patient onset of the symptom, patient whether the patient is self-present to the hospital or patient calls to the emergency medical service. If the patient present to the himself to the PCI center, then we go for primary percutaneous intervention strategy. Then aim should be to give a wire crossing within 60 minutes. And if patient presenting to the calls to the emergency medical service, then whether patient is is in non-PCI center. If patient is or patient is in the ambulance. If a patient is the non-PCI center or PCI capable center, then if a PCI from that non-PCI service, if a PCI capable center that possible to take the patient within 2 hours, then we go for the primary percutaneous intervention and transfer the patient to PCI capable hospital. So, and again, aim should be within 90 minutes. Air crossing should be there, and you should do her PPCI. If a patient is not able to reach PCI capable hospital or patient in ambulance, then directly go for the fibrinolysis strategy. And aim should be give fibrinolytic dose within 10 minutes. And after giving a fibrinolytic dose, I can transport the patient to the PCI capable hospital for the angiography or angiography. So this is again the same thing. After giving transfer the fibrinolytic dose, bolus fibrinolytic dose, transfer the PCI center, and if patient meet the reperfusion criteria, if yes, then routine PCI strategy should be done again. If it does not meet the reperfusion criteria, then rescue PCI should be done after 90 minutes. So reperfusion strategy, this is the primary coronary intervention that I have told already. Another is the fibrinolytic strategy. Best result obtained if you give that within 2 hours, and PCI for if you more than 2 hours, more than 3 hours, usually give, go for the PCI strategy rather than fibrinolytic strategy. And fibrin specific should be used. Most commonly used to fibrinolysis are the streptokinase, altiplase, reticlase, antireticlase. All those are available in India, and these are the dose. I am not going detail, but you should remember all the doses. So, what are the contraindications of the fibrinolytic strategy? Absolute contraindication is having intracranial hemorrhage, ischemic stroke, patient in 6 months, and central nervous system damage or neoplasm or AV malformation, recent trauma, surgery or head injury or spine surgery, or gastrointestinal bleeding ongoing, within past month, or any bleeding disorder excluding the menses, and any aortic dissection is there, or non-compressible puncture site within 24 hours. And related contraindication transit is estimated within 6 months, or for anticoagulant therapy, pregnancy, or within 1 week of a postpartum refractory hypertension or hypertension, or systolic blood pressure more than 180, or diastolic blood pressure more than 110, and advanced liver disease, infective endocarditis, active peptic ulcer, or prolonged traumatic resuscitation. So again, when you give the prophylaxis, we should assess whether it is adequate or not. So monitor assessing the reperfusion after fibrinolysis. We should monitor for the pain or the symptom relief, hemodynamic stability, and electrical stability or changes in ECG. ECG sign is that suggests adequate reperfusion after 60 minutes. These are the ST resolution, ST elevation that have happened, that ST elevation resolution more than 50% for a terminal TUA infarction or reperfusion arrhythmia. So after the primary reperfusion strategy, we go for antithrombotic and anticoagulant doses. But antithrombotic we usually go for PCI, we usually give the aspirin loading dose and ticagrelor prasugrel, or if these are not available, we go for clopidogrel 600 milligram. And if patient have a fibrinolytic strategy, we give again aspirin and clopidogrel. Anticoagulant similarly, we after PCI we go for after PCI, we give unfractional heparin or enoxaparin or bivalirudin, but not fondaparinux. For fibrinolytic strategy, we go for unfractional heparin or enoxaparin. So these are the ECS guideline doses of aspirin, clopidogrel, and prasugrel, ticagrelor, and anticoagulant on heparin. So for the time purpose, I'm not going through all this. But for unfractional heparin, initial treatment, you should give a 70 to 100 unit per kg with IV infusion, titrated to achieve a APTT of 60 to 80. And during PCI, again, 70 to 100 unit per kg IV bolus according to the ACT in case of unfractional heparin pre-treatment. Similarly, in enoxaparin, we usually give the 1 milligram per kg body IV twice daily subcutaneously here. And if patient having creatinine class less than 30, we usually decrease the dose to 1 milligram per kg body once daily dose. And during PCI, again, if patient have received already enoxaparin within 8 hours, so we need not to give no additional dosing. But if subcutaneous dose enoxaparin is more than 8 hours before the PCI strategy, IV bolus of 0.3 milligram per kg enoxaparin should be used. So these have already discussed already. From 0 to 9 within 9 minutes, we should go for ECG and alert the cath lab and bypass the ED. Again, go for aspirin loading dose and prasugrel, ticagrelor, clopidogrel loading dose. Give oxygen, beta blocker. Beta blocker, if patient presenting with heart failure, no need to give high beta blocker. Or presenting with heart failure, no need to give IV beta blocker. But patient no heart failure, he can go give the beta blocker. And similarly, upward purchase pain relief we can give. And within 9 minutes, we should have a wire pressing for this patient. And on fractional heparin, we can use the peri procedure. So after procedure, again, we use the 12 antiplatelet for up to 1 year. So these are the ST elevated microinfarction. Similarly, non-ST elevated acute coronary syndrome, the goal of management are relief ischemic pain, hemodynamic status assessment and correction, early risk stratification, choice of therapy. We should see again whether PCI or CAPG or conservative type, and antithrombotic treatment, again echocardiography, and prevention of the recurrent or ischemia or arrhythmia, and improvement of long-term prognosis with a SC inhibitor or statin. So risk stratification and non-ST elevated infection by the TIMI 30 days score or GRACE score. And TIMI score, these are the risk stratification scores that if score is 6 to 7, then mortality is about 40%. And if score is 0 to 1, the mortality is about 4%. So if patient with a AC, not NSTV, we usually have a ischemic guided therapy or any invasive guided therapy. So early invasive strategy, again, immediate that invasive strategy should be done within 2 hours. Early invasive that should be done. Invasive strategy should be done within 24 hours. Delayed invasive that we should do after 24 hours to 72 hours, or after 24 hours, that is 24 hours to 72 hours. So these are the criteria. I'll go through later how we can go for immediate and early invasive, what is delayed invasive strategy. So whether we go for early invasive or ischiocardiac therapy, usually we give the patient the TAPT, dual antiplatelet therapy and anticoagulant therapy, and along with the patient nitrate purchasement, beta blocker, and calcium channel blocker. So this is again ECS guideline 23 guideline. This is classify the patient into very high risk, and non-high risk. Very high risk, those are having hemodynamic instability or recurrent ongoing chest pain or acute heart failure, life-threatening arrhythmia or cardiac arrest after the presentation, mechanical complication or valvular regurgitation or recurrent dynamic ECG changes. These are very high risk, and they need immediate invasive strategy that is within 2 hours. Second, high risk strategy, these are confirmed diagnosis of STEMI based on the PCS algorithm and GRACE score more than 150, trans ST elevators and the dynamic ST changes. These are the high risk category. Again, uh, uh, these patient early invasive strategy should be given, that is within 24 hours. And non-high risk category, if these things are not present, this patient are a non-high risk category, and if patient invasive strategy that should give more than 24 hours, after 24 hours can be given. So these are the managed ST and non-ST elevated mitral infection. What are the complications of mitral infection? This can present with arrhythmia, conduction block, rupture of the free wall or ventricular rupture of the ventricular septum or papillary muscle, and patient subsequently may have regurgitant murmur, and patient can have aneurysm and cardiogenic shock. So if a patient present after chest pain after myocardial infarction, this can be due to recurrent ischemia, and this can happen 20 to, in 30 to 30% thrombolytic patient, or 10% in PCI patient undergoing PCI. Or other cause of chest pain, incomplete revalvularization or infarctor extension or reinfarction or post-infarctal angina. So in this patient, we go for a serial cardiac biomarker, and we would monitor the, as I told, the CKMB. We can monitor to diagnose the reinfarction. And treatment, again in the reinfarction, we aggressive medical therapy is given nitrate, beta blocker, heparin, aspirin, and revascularization if reinfarction is suspected. So these are the this is my topic. Any question you can put in chat box, so you can ask. Thank you.
That's very good topic, sir. Actually, you have elaborated a lot or a short. I think the points that to be taken is highly selective troponin, specific troponin has come replaced the troponin these days. That is point
Yes,
number
that's
one.
correct.
And point number two, the gray score which was there somewhere back has come into the picture now. Gray score of more than 140 is one of the major
Risk
risk
factors, yes, yes.
Yes. And actually, they also highlighted the chest pain after MI. So they have pointed type 4 MI also here. So these are three new points, I think, sir,
Okay.
as compared to the previous guidelines. So if the participants are having any doubts, they can post in the chat box. Without any delay, we'll move on to the next speaker. That is Dr. Beswajit sir. This is Naik sir. He will be talking about heart management of heart failure. Sir, off to you, sir. Beswajit sir. Please start your presentation.
Molly, hello.
Hello, sir. Please
Molly,
start.
you have just disabled my sharing of screen.
Acha, acha. I will just give it to you.
What is your name?
Name. I think it's from Satyajit.
तो वो बोलो ना. You can share now.
No, no, no. Is it visible?
Yes, visible.
Visible, sir.
It's visible now? Audible? Molly?
Yes, sir, it's audible. It's audible. It's audible. Please proceed.
Fine. My topic is heart failure. So the incidence is 1 in 1,000 population per year, but in aged population like more than 85, it's can up to 10 cases per 1,000 cases. The male has more predilection, like twice as compared to females. Median age of presentation is 76 years. Approximately 30 to 40% of patients with CHF are hospitalized each year, but 50% of the patients will die within the 4 year of diagnosis. And the median survival of in men is 3.2 years. In the women, it's little higher, it's 5.4 years. The most common cause is the progressive heart failure, but sudden death can be occur in up to 45% of patients. Now coming to definition, persistent NIA classification grade 3, V and 4 symptoms that limit daily activities and occur despite adequate pharmacological treatment, and it's usually associated with EF of less than 30%. It's called heart failure. Now coming to classification, there is actually three classes are there. That's most common is the heart failure with the reduced ejection fraction, where the ejection fraction is less than 40%. It's called systolic failure. And second one is the heart failure with the preserved ejection fraction, where ejection fraction may be normal more than 50%. It's called the diastolic heart failure. And the third category is heart failure with the mild reduced heart failure ejection fraction. It's called HFMREF, which is in between 40 to 50. Types, it can be systolic pump failure or diastolic like filling problem, left-sided or right-sided. Acute, it is in the emergency situation like in the acute MI, or chronic, it's in the long period of time like in DCM. Coming to etiology, the most common cause is coronary disease, hypertension, alcohol, idiopathic dilated cardiomyopathy. Other causes can be valvular or non-cardiac causes like thyrotoxicosis, septicemia, Paget's disease. Coming to pathophysiology, it's summarized as an imbalance in the Starling's force or an imbalance in the degree of end-diastolic fiber stretch proportional to the systolic mechanical work. Here is the first, there is cardiac muscle injury leading to damage. Then in step 2, it is a contractility issue, that is contractility decrease. And third is early changes like increased heart rate, left ventricular hypertrophy. Here the heart tries to compensate. In the fourth, there is activation of the compensatory mechanisms to maintain the cardiac output. Then leads to severe LV dysfunction. There is a dilatation of the ventricle leading to decreased cardiac output. And last is that all the chambers has been dilated, leading to arrhythmias and emboli. So here you can find there is decrease the muscle fiber myofibril length size, but there is increased ventricular size chamber. The other conditions contribute to heart failure like increased BMR, iron overload, hypoxia, severe anemia, electrolyte abnormality, cardiac arrhythmias. So now coming to the sign and symptoms of left ventricular failure, like unexplained cough, low oxygen saturation, cyanosis, diaphoresis. You can get the third heart sounds, reduced urine output, severe respiratory distress, and fatigue. That is in the pulmonary condition, you can find the rails at the base and bronchi. You can find the raised JPP also. And coming to right heart failure, the etiology may be mainly in inferior MI or COPD or ILD cases. Pathophysiology is decreased right-sided cardiac output, leading to increased right ventricular pressure, which leads to increased pressure in the right atrium and venous system. But here the symptom and the signs like marked JVP, but the chest is clear. And there may be weight gain, ascites, hepatomegaly, and abdominal pain. Compensatory mechanisms in both the failure is like activation of the neurohormonal system, RAS system activation, and ventricular hypertrophy. Coming to neurohormonal system, there is stimulation of the epinephrine leading to vasoconstrictions and increased SPR leading to further decrease in the cardiac output. And vasopressin which increase in vasopressin leads to mild vasoconstriction and renal water retention. Then activation RAS leading to aldosterone is released and leading to increased sodium retention, water retention, which further worsening the preload, increase the preload and worsening failure. Here is the pathway. The renin activated, the renin convert to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme, where the role of the angiotensin 2 increase the peripheral vasoconstriction, leading to afterload, increase the afterload, which decrease the cardiac output. Also, angiotensin 2 leads to activation of the aldosterone secretion, leading to salt water retention, which further increase the plasma volume, leading to preload, increase preload, and increase the cardiac workload, leading to heart failure. There is ventricular hypertrophy due to long-term compensatory mechanism and increase in the size due to the increased work of the myocardium. Diagnostic test, further we can use the test like medical, first know from the history and physical examination by measuring serial measurement of the BNP, lab test like CBC, metabolic panel, hyperfunction test, thyroid function test. Echo, main diagnosis is echo to assess the ejection fraction. X-ray, ECG, cardiac stress test, cardiac catheterization, CT, Holter, and heart biopsy and exercise testing, 6-minute walk test. We can know the diastolic heart failure by the signs and symptoms of the heart failure and the presence of normal or systolic LV systolic function should slightly reduced. That is by from the 2T echo. And we know from the cardiac catheterization or Doppler that there may be abnormal LV relaxation or there is diastolic distensibility or diastolic stiffness. Coming to staging, there is two well accepted staging like ACC, AHA, and NIA classification. Coming to ACC stage, there is 4 stages. A is at high risk but without any symptom, or any also no structural disease. B is the structural heart disease but without any symptoms. C is the structural heart disease with prior or current symptoms of heart failure. But D is the refractory heart failure with symptom. Coming to NIA classification, there is class 1, which is no limitation in the physical activity. 2 is slight limitation. 3 is marked limitation in the physical activity. 4th is the unable to do the normal physical activity or any physical activity. That is heart failure at the rest also. Symptom can be at the rest. So this SSC classification stage A, B, C, D. A, B is the at-risk heart failure. So stage A is, as I have discussed, it is the at-risk heart failure, but there is no structural disease or there is no symptoms. So like in patients of hypertension, atherosclerosis, diabetes, obesity. So here the therapy is to give the only healthy lifestyle, prevent vascular coronary disease. We can use SE inhibitor and ARB in appropriate patients and can use statin also. In stage B, when there is structural heart disease is added with stage A, then it's coming to stage B. So here, patient is like previous MI, LV remodeling, LVH. So here the drugs is like SE inhibitor, ARB, and beta blockers can be added. In selected patient, we can go up to ICD and revascularization therapy. When with this stage B having symptoms, then it comes to stage C. That is the structural heart disease with symptom of heart failure. So here it can be two subtypes like heart failure preserved ejection fraction or reduced ejection fraction. In preserved ejection fraction, we can treatment like diuresis to relieve congestion. That is can follow guidelines driven indication of the comorbidities like hypertension treatment, AF treatment, CD treatment like that, or revascularization. But in reduced ejection fraction, we can use diuretics, SC inhibitor, beta blockers, and aldosterone antagonist. And selected cases, hydrogen or decoction can be added. And if there is still refractory symptoms of heart failure at rest, then it's come to, and despite the well-treated medical therapy, then it comes to stage D. That's called refractory heart failure, where patient is the mild heart failure symptoms at rest. Here we can do advanced care measure like heart transplant, chronic angiotropes, patient may be on angiotropes for a long period of time, or mechanical circulatory system support patient may need, or last ICD. So, in patients having heart failure with reduced ejection fraction in stage C, or maybe in any class of NIA classification, the first class 1 and level A evidence is to use SC inhibitor ARB and along with beta blocker. And if the patient having a volume overload, then we can use loop diuretics. And if the patient is having also African American types and class 3 symptomatic and near class 3 4, we can add hydrogen and nitrates also. And if patient is having normal renal function, then we can add aldosterone antagonist to them. So three basic treatment strategies like pharmacological, device, or surgical, or lifestyle. So coming to pharmacological, it's mainly the correction of the potential reversible cause like anemia, hypothyroid, malprodrug disease, or MI. Salt restriction less than 4 gram, diabetics, vasodilator therapy like SC inhibitors, ARB, beta blockers, and restriction of fluid. And avoiding the NSAID, short-acting CCBs, and low salt diet, advise moderate alcohol. So rationale of the medication is depend on improvement of the symptoms like the diuretics and digoxin, and the improvement of the survival. Survival benefit is with the beta blockers, C inhibitors, conversion blocker, and ARBs. So here is the 4 types of classes, like patients having congestion and patients having low perfusion. How you know that a patient is having congestion? Evidence of congestion by orthopnea, there is maybe ascites, there is third heart sound, elevated edema. So when looking this, there may be congested. And how can you know from the low perfusion state patient, like no narrow pulse pressure, pulses alternate, school extremities, mental confusion. So these are the low perfusion. So by if there is congestion at rest or not, or perfusion at rest, by this we can getting into 4 classification of the patient, like warm dry, warm wet, cold wet, and cold dry. So if patient is warm and dry, means patient is the patient is no, there is no congestion at all, so patient is dry. Warm means there is good perfusion, so it is warm. So patient first category is warm and dry. And cold and wet means, cold means there is low perfusion, and wet means there is congestion is present. So accordingly, the treatment is also different. So warm dry patient can be treated at the home. So it means it's compensated. Oral therapy is needed. But warm and wet means congested. So patient can be patient has to admitted in the hospital. And here is the main reason, as there is wet, so patient needs diuretics therapy. And in cold and wet, patient needs ICU. So here is patient is in the decompensated state, so needs diuretics and vasodilators and inotropes for the, as it is cold, so perfusion low, so we have to use the inotropes. And cold and dry state, there is a low flow state. Basically it is the BP is low, so we need to mainly the support the blood pressure. So in giving the inotropes. So when we can use the invasive hemodynamic monitoring in acute heart failure, so there is actually no role for routine or periodic in invasive monitoring, but we can use it in when there is, we don't know the fluid state of the patient, or there is perfusion problem, or systemic or pulmonary vascular resistance, or there is whose systolic pressure remains low and is associated with the symptoms despite the therapy, and whose renal function is worsening with therapy, and who requires vasoactive agents, and who may need the uh, consideration for the mechanical circulatory support or cardiac transplantation. So, what is the role of biomarker? There is need of serial biomarker BNP measurement on admission and before the discharge, only for the prognosis and tailoring of the our treatment. A fall of more than 30% shows that the successful treatment. And then BNP of less than 100 have a negative predictive value, and for more than 400 is likely heart failure. The other causes of high BNP, like in cardiac causes like heart failure, other causes like acute coronary syndrome, LVH, peripheral disease, atrial fibrillation, non-cardiac causes like advancing age and renal failure also. So very careful in the CKD and also in the elevated in the septic shock patient and severe bone patients. Coming to device and surgical management. So first option, if the causes of the heart failure can be treated surgically, and several therapies like pacing, ICD, ventricular assist device, or heart transplant. Recommendation is to give in patients of NIA class 3 and 4 with long prolonged QRS. And an ICD may be used in patients with apnea to prevent sudden cardiac death. A left ventricular assist device may be used as a bridge therapy to transplant or destination therapy. Here is the pacemaker. There is biventricular left ventricle, right ventricle, and there is pacemaker with implantable cardiac defibrillator. So here is a clinical diagnostic scoring system known as the PRIDE score, which has elevated BNP, edema, chest X-ray, orthopnea, fever, absence of fever, antibiotics, age, rails, and absence of cough. If the score is more than 7, then the heart failure is more likely. So at ICU, the treatment mainly depend on relief symptoms and stabilize hemodynamics. Coming to oxygen therapy, oxygen therapy should not be used as hypoxia leads to vasoconstriction leading to further increased SVR leading to decreased cardiac output. So only oxygen is given when there is saturation less than 92. Positive pressure ventilation recruits the edematous lungs, improving compliance and gas excess, decreasing the work of breathing. And it leads to positive blood pressure, decreases the preload, so LV afterload immediately. CPAP delivered by face mask reduces the need for intubation and mechanical ventilation. So if patients coming with heart failure, you first see the congestion. Is there any presence of congestion or not? So if there is presence of congestion, which is 95% of the patient, then the patient is called as wet patient. So then we look for the adequate peripheral perfusion is there or not. If adequate peripheral perfusion is present, then the patient is wet and warm as the perfusion is adequate. So in this type of patient, this can be fluid two types, vascular type or cardiac type. Hypertension, vascular type, and cardiac type means congestion. So in vascular type, we can use vasodilator, and in the cardiac congestion type, we can use mainly diuretics. And if there is peripheral perfusion is low, adequate is not adequate, so it's low, then we call it as cold and wet. So in this case, if we can, then we look for the BP. If BP is less than 90, then we can use the inotrophazine. And if the BP is more than 90, then we can use the vasodilators and diuretics. And similarly, if the dry patient comes with perfusion, adequate perfusion, that is called dry and warm, then you can simply give the oral therapy. That's all. And if it's no, there is soft maybe present, dry and cold, then we can use here fluid. So diuretics have a clear role in reducing the congestion, reduce the symptoms mainly. So it must be started the immunity dependent itself without any delay. So loop diuretics is choice, more effective and preferred. Diuretics should be administered at doses sufficient to achieve the optimal volume status and relieve the congestion. As it can lead to rapid deterioration of the intravascular volume, which results in the hypotension or renal dysfunction. If there is no response to diabetes, then there may be other disease process, or we can use their advanced hemodynamic monitoring for that. If volume overload is confirmed, then we can increase the dose of the diuretics. Ultrafiltration moves the water and small to medium weight solutes, so leading to reduce the volume overload. A randomized acute heart failure trial in patients with cardiac symptom and persistent conditions has failed to demonstrate a significant advantage of ultrafiltration over the bolus diuretic therapy. Coming to parenteral therapy, like vasodilator, like intravenous nitroglycerin, sodium nitroglycerin, and acetaldehyde. Nitrates, IV nitroglycerin acts primarily through vasodilator, lowers the free layer, and may help to rapidly reduce the pulmonary congestion. Patients with heart failure and hypertension and coronary ischemia are the and significant metal regurgitation as the main candidate. And then nitroglyceride, the beauty is preload reduction and afterload reduction. So as it is a vasodilator and arterial dilator, and also it dilates the pulmonary vasculature too. Nesitide is an human BNP, reduces the LV filling pressure, but it has a very variable effects on the cardiac output and urine output. These are the dosings of the vasodilators: nitroglycerin, nesitide. I'm skipping. Coming to inotropes, parenteral inotropes, I will remain as an option to help the subset of patients with heart failure with refractory to other therapies, and mainly of who is suffering from the consequences from the end organ hyperperfusion. And it is considered only in patients with systolic dysfunction who have low cardiac index and evidence of systemic hyperperfusion. The inotropes like dopamine, milrinone, calcium stimulant like levosimendan, and norepinephrine. Maintenance of GDMT, goal-directed medical therapy. The patient's maintenance heart failure medication should be carefully reviewed on admission to ICU, and it should be decided whether adjustments should be made as a result of the hospitalization. We should not stop all the heart failure medication. In the majority of the patients with reduced ejection fraction who are admitted to the hospital, oral heart failure therapy should be continued, and it may even uptitrated. Coming to mechanical support, the conventional indication for there is a one is IVP, another is ventricular assisted device. These the mechanical support is circulatory support is mainly to support the circulation before any surgical correction of the specific acute mechanical problem or during severe acute myocarditis and in selected patients with MI. So ventricular assist devices are effective in both the management of acute decompensated hemodynamically unstable at reduced ejection fraction patients, which are refractory to inotropic support. We can use adrenaline vasopressin antagonist like which improve the serum sodium in hypervolemic hypernatremic states. So summaries in ICU, like pulmonary edema and shocks are two main manifestations of ADS in ICU. Diagnostic modalities should incorporate the clinical picture, chest X-ray, BNP, and echo. IV diuretics is the mainstay of therapy, as it is the main drugs like decrease the symptoms. And decision for the advanced human monitoring is an important issue. Discharge out of the ICU and home is an important aspect of care. Thank you.
That is a very nice presentation, sir. If any queries by the participant, we should start oxygen. More than
We should start oxygen early. If it's less than saturation like 92, then we can start. Otherwise, it leads to vasodilation and increase the
And
cardiac,
uh,
decrease the cardiac.
worsens coronary vasospasm and worsens the failure curve. Okay, sir. Thank you.
Yeah,
Without
yeah.
any delay, just I want to
Thank you.
introduce Dr. Abhilash Das, Associate Professor, IMS in some hospital, Bhubaneswar, to talk on acute right heart failure and also on pulmonary embolism. Sir Abhilash, sir, please welcome and after you.
Hello, audible?
Yes, sir, you're audible. You're audible. Please proceed.
Good evening, everyone. So my topic is acute right heart failure and acute pulmonary embolism. So cardiogenic shock that comes from left ventricular failure is very common presentation in the ICU. In contrast, right ventricular predominant heart failure causing shock is less recognized. The right ventricular function is influenced by the preload, afterload, myocardial contractility, and also non-cardiac factors like pericardial compliance and thoracic compliance also. So right ventricle is more sensitive to afterload changes. In chronic stages of right ventricular failure, there will be dilation and hypertrophy of right ventricle, leading to tricuspid regurgitation, myocardial hypertrophy, and annular dilation. But in acute decompensation, there will be systemic hypoperfusion, which is due to low cardiac output state. So rapid identification and treatment of the underlying cause is very mandatory. So this is a picture showing various type of right ventricular failure. One is hypocontractile right ventricle in the extreme left. You can see this is the normal diagram and how there is contraction of both the volume and pressure decreases. And in right ventricular volume overload, there will be shifting of this curve to right so that the pressure will be high and volume will be also high. And in pressure overload states, there will be high pressure of right ventricle and volume will be less. So what are all the causes of acute right ventricular failure? One is preload causes, one is afterload causes, and one is contractility dysfunction. So in preload states, that is acute renal failure leading to fluid overload, leading to increased venous return. One is acute valvular insufficiency, like tricuspid regurgitation. One is patent foramen obel, that is congenital heart disease. In afterload causes, one is pulmonary thromboembolism, and one is hypoxia from any pulmonary etiology like pneumonia, ARDS, etc. And positive pressure ventilation also leads to increased right ventricular pressure. And contractility dysfunctions like acute right myocardial infarction, then myocarditis due to any cause, and supraventricular or ventricular tachycardia that leads to AV dysynchrony. All will lead to right ventricular failure. How this right ventricular failure presents? Raised JVP, that is due to high right atrial and right ventricular pressure. Then hypotension, hypoperfusion, cold extremities due to low cardiac output. And as there is edema states in the right side of heart, that will lead to acute kidney injury and liver failure that manifests as jaundice. And there will be pansystolic murmur due to tricuspid regurgitation. In chronic right ventricular failure, there will be hepatomegaly, abdominal distension, ascites, and peripheral pitting edema. In severe forms, the right ventricle dilates, that will lead to the shift of interventricular septum towards the left, which will compromise the left ventricular filling, and there will be reduction of the cardiac output and reduction of the left ventricular performance. So how to diagnose acute right ventricular failure? Most common and most reproducible is echo. In echo, you can see for the TAPC, that is tricuspid annular plane systolic excursion. If it is less than 17, definitely there is some problem in the right ventricle. And tricuspid regurgitation jet velocity. If it is more than 2.8 meter per second, so definitely there is high pressure in the right ventricle. And we can also see right ventricular fractional area change. If it is more than 1, the right ventricle is the area of right ventricle is more than left ventricle, the size has been changed, then definitely there is dilation of the right ventricle. And IVC also we can see, if it is more than 21 mm and there is no respiratory variation, that is plethoric IVC, that is diagnostic of right ventricular failure and fluid overload. And pulmonary artery catheter also we can use to see the indices of right ventricular failure. Pulmonary artery pulsatility index, that is PAPI, it is less than 1.85 and even it may come down up to less than 1. And right arterial pressure to pulmonary capillary wedge pressure, the ratio will be more than 0.86 in right ventricular failure. So echo and PA catheter, these two are most commonly used to diagnose the right ventricular failure. What are all the principles of management? First and foremost is the early recognition of the disease. Then preload optimization with volume status, and afterload optimization, including the perfusion pressure things. Then contractility management, including the rhythm management. So early recognition, preload optimization, afterload optimization, and enhancing the contractility of the heart and rhythm management. So coming to the medical management, first is volume optimization. Most of the patient, they are hypervolemic. So we can use diuretics, that is intermittent bolus doses or even infusions, so that there will be preload will be low, and that will lead to low means optimal preload, and that will lead to less stress on the right ventricle, so that it will work in a proper way. And then coming to the afterload optimization, pulmonary vasodilator therapy, intravenous epoprostenol has been used in a good effect, so that there will be pulmonary vasodilation, the afterload will be less, and the right ventricle will contract against a lesser resistance vessels. Then pressure and inotropic support. In a failing heart, we have to maintain the mean arterial pressure by either noradrenaline or dopamine, and inotropic support with milrinone or dobutamine also will help, so that there will be better contractility. And any cases of bradyarrhythmia or tachyarrhythmia should be managed. The target heart rate should be between 80 to 100, optimal heart rate. All these things will maintain the forward flow of the right ventricle, so that all the preload coming to the left ventricle will be optimal and cardiac output will be optimal. So this is the medical management. There is a thing called device management. In device management, you can use ultrafiltration. That is, if by using diuretics, if you are not able to maintain not able to excrete the extra fluid, then you can do dialysis. Then mechanical ventilator. Usually mechanical ventilation has a two type of effects on right ventricular failure states. So to optimize the right ventricular function, you have to minimize the PEEP and use the lower tidal volume. Means that tidal volume that is optimal for the patient condition for oxygenation and carbon dioxide washout. You have to use this little bit low tidal volume strategy with low PEEP strategy. Then intraarterial shunting can be done to decrease the effect of failure of right ventricle. Then temporary mechanical circulatory support devices like right ventricular bypass systems, Impella RP and tandem heart. These two things can be used, that is right ventricular assist devices. This can be used, and there will be bypass of the right ventricle to give rest to the failing heart. And finally, VA ECMO in right heart as in left heart failure, in right heart failure also. ECMO at the earliest stage can help in recovering of the failing heart. So what are all the targets of these devices? Definitely you have to maintain CBP in a lower range, that is less than 14 millimeter of mercury. Pulmonary capillary wedge pressure should be maintained in less than 18 millimeter of mercury. Cardiac index at least more than 2.2 liter per minute per meter square. And anticoagulation target will be 1.5 to 2 times upper limit of the normal. So this is a flow chart. So summarizing the management of acute right heart failure. So once you have diagnosed the acute right heart predominant failure, that is early recognition and assessing the severity of right heart failure by the clinical sign and symptoms. Physical examination you can do, labs like urea creatinine and uh, AST, ALT, and bilirubin. All these you can see to know whether the parameters have increased or not. Then echo parameters like TAPSE and all, and pulmonary artery catheter you can use for the diagnosis of right heart failure. Then assess the underlying etiology. Treat reversible cause. If there is any cause, reversible cause, you have to treat so that it will reverse the acute failure state. Then optimize preload by using diuretics and ultrafiltration. Then optimize the inotropy, that contractility of heart, by using milrinone, dopamine, and vasopressors like noradrenaline. Then optimize the afterload by decreasing the pulmonary vasoconstriction by pulmonary vasodilators. And other measures like ventilatory management, as I told, low PEEP, low tidal volume management, and rhythm optimization, preventing tachy and bradycardia. Even if after all these measures there is worsening of the hypotension and there is hypoxia and end organ hypoperfusion, then there has to be assessment by multidisciplinary shock team and consideration for right ventricular mechanical circulatory support devices. If there is no oxygenator need, then tandem right ventricular assist device and impeller both can be used. And if there is a need of oxygenator, then along with the tandem right ventricular assist device, you can use VA ECMO. So this is all for the acute right ventricular failure. And one of the most common causes of acute right ventricular failure in ICU is acute pulmonary embolism. Coming to this acute pulmonary embolism. So what are all the risk factors for the pulmonary embolism? As we know, there is a triad called virtuous triad, that is circulatory stasis, endothelial injury, and hypercoagulable states. Circulating stasis is caused by immobility, pregnancy, postpartum states, previous venous thromboembolism, and post-thrombotic disease syndrome also, and disease states like septic shock, heart failure, IBD. Then endothelial injury can be caused by catheterization, trauma, any surgery like orthopedic, urological surgery, gynecological surgery. This will predispose for the development of pulmonary embolism. Some hypercoagulable states like antithrombin 3, protein CAS deficiencies, vector 5 Leiden mutation, use of oral contraceptives, estrogen replacement therapy, antiphospholipid antibody syndrome, and in any malignancy, there is hypercoagulable state that can lead to pulmonary embolism. So what is the pathophysiology? Once there is blood stasis, then and lead to hypoxia wall injury, there will be accumulation of the thrombin and fibrin deposition. Pulmonary embolism can occur 3 to 7 days after deep vein thrombosis because of occlusion of the vessel and breakup of the thrombus. Then hypoxemia will lead to intrapulmonary shunting and in VQ mismatch. If there is a patent foramen oval, worsening of the hypoxemia and paradoxical embolization can also occur. So increased pulmonary vascular resistance will be there because of clot blocking the pulmonary vessels, leading to pulmonary hypertension that will cause right ventricular outflow tract obstruction, and flow will be low. That will eventually lead to left ventricular preload, low left ventricular preload, and low cardiac output. So this is a flow chart showing how the occlusion of pulmonary artery will cause these problems. Occlusion of pulmonary artery leading to pulmonary AV shunting with hypoxia, that will lead to right ventricular ischemia, that will cause increased myocardial oxygen demand and RV ischemia. Then increased right ventricular afterload will cause increased right ventricular pressure, that will lead to right ventricular dilation. And once the dilation occurs of the right ventricle, there will be neurohumoral activation, and also increased tricuspid regurgitation will also increase the right ventricular pressure. All this will cause reduced right ventricular contractility, reduced right ventricular stroke volume. Eventually, that will cause reduced left ventricular preload and reduced cardiac output and systolic blood pressure. And all these will result in a reduced coronary perfusion and oxygen delivery. This is the pathophysiology. So classification, according to the duration, there can be acute pulmonary embolism, subacute or chronic pulmonary embolism. According to the location, it may be saddle, it may be lobar, it may be segmental, or it may be subsegmental. According to the symptoms, it may be symptomatic PE or asymptomatic pulmonary embolism. And according to the clinical stability, stable pulmonary embolism or unstable pulmonary embolism. What are all the clinical features? In DVT, there will be low-grade fever, swelling of the lower limbs, redness, tenderness. And with DVT, if there is a pulmonary embolism, there will be sudden onset of dyspnea, rheumatic chest pain, hemoptysis, dizziness, syncope, and loud P2. Once we are searching whether there is pulmonary embolism, we have to see for the pretest probability. It can be done by 2-3 criteria. One is Wells criteria, one is modified Geneva score. In Wells criteria, you have to see the things that is, one is clinical sign and symptom of DVT. If it is there, then +3. Pulmonary embolism in the first diagnosis, or equal likely it is +3. If heart rate is more than 100, it's 1.5. Immobilization in last 3 days or surgery in the previous 4 weeks, it is also 1.5. Previous diagnosis of PE DVT, 1.5. Patient is having hemoptysis or known malignancy, it is 1. So the probability is low if the score is less than equal to 2. 2 to 6, it is moderate probability, and more than 6 is high probability. And in Geneva, revised Geneva score also, previous PE-DVT, heart rate, surgery, hemoptysis, active cancer, all these are 1 point. And if the score is less than 2, low probability. If it is more than 2 to 4, it is intermediate probability, and more than 4 is high probability of getting pulmonary embolism. So one criteria is there, it is called pulmonary embolism rule out criteria. In low probability cases, if you can rule out the pulmonary embolism, there is no need to investigate further. It includes age less than 50 years, initial heart rate less than 100, and oxygen saturation more than 94, no leg swelling, no hemoptysis, no surgery trauma. All these things will rule out the pulmonary embolism in low risk cases. Coming to the diagnosis, first thing is we can use biomarkers. Most sensitive is the D dimer. It can be elevated both in the DVT and pulmonary embolism. So the enzyme linked immunosorbent assay is the high sensitive test for the pulmonary embolism. The pretest probability model of D dimer. So with all the with have intermediate and high probability of pulmonary embolism, we have to test the D dimer. And this D dimer can be falsely elevated in inflammation, carcinoma, infection, pregnancy, and surgery. Better indicator of D dimer is age adjusted D dimer, which is better predictor than the single value. And even we can see the TROPI and proBNP in suspected pulmonary embolism cases. Then we can do ABG. In ABG, there will be hypoxemia, hypocapnia in the initial states, and increased EtCO2, and there will be metabolic acidosis. In ECG, we can see normal ECG or sinus tachycardia, that is 44%. That is most common finding in ECG in pulmonary embolism. There may be associated right bundle branch block. There may be right ventricle strain pattern, T wave inversion in the inferior leads. Right axis deviation may occur in 16% of cases. And S1, Q3, T3, these waves can be seen in 20% of cases. These are all the ECG changes we can find. So most common is sinus tachycardia. And chest X-ray also, well, most of the times it is not. Some specific changes can occur like cardiac enlargement, pleural effusion, elevated hemidiaphragm, atelectasis, and local infiltration can also occur. Some specific signs like focal oligoemia, that is called Westermarck sign, and the peripheral nodules of these nodules, these are called Hampton's Hawk, and some pallor sign also can be seen in X-rays. So focal oligemia and Hampton's Hawk. One of the definitive diagnoses is echo. Right ventricular dilation occurs in acute pulmonary embolism, RV more than LV, paradoxical interventricular septum motion towards the left ventricle, and tricuspid regurgitation occurs with IVC more than 21 mm. As I told in the acute right heart failure, all these features of acute right heart failure occurs here also. Pulmonary hypertension is there, and McConnell sign, right ventricular hypokinesia. The definitive diagnosis is CT pulmonary angio. It is high resolution images, segmental to subsegmental pulmonary arteries. Compared with the normal angiography, it has excellent sensitivity and specificity and accuracy. But it can be inconclusive in 10% of cases. 10% small peripheral emboli in subsegmental arteries cannot be seen in CTPA, but the clinical significance in critical ill is unknown. But poor prognosis is there if this subsegmental pulmonary embolism, these are not treated. So it can assess the severity of pulmonary embolism the RV by LV ratio and high thrombus load and central location of clot, these are all indicating poor outcomes. And we can use VQ matching or mismatching, that is lung scintigraphy, to a good extent in patients who are pregnant or who are have renal failure or who are having any allergy to the contrast. We can use scintigraphy, equivalent diagnostic yield with lower radiation dose. And sometimes MR angio and contrast enhanced MR also can be useful to diagnose the pulmonary embolism. This is a picture showing the main pulmonary trunk, right and left trunk, and in the left trunk you can see there is a massive embolus that will cause pulmonary embolism. So another thing is to screen the DVT, we can use Doppler ultrasound, high accurate in symptomatic and proximal DVT, proximal compression ultrasound with 4-point compression, that is femoral vein at the saphenofemoral junction and popliteal vein in the both limbs can be done for pulmonary embolism when CTPA is contraindicated. So it is the diagnostic algorithm. Suspected pulmonary embolism having low probability or high probability or moderate probability. If there is low probability, as I told, we can use the pulmonary embolism rule out criteria. If the rule out criteria is negative, there is no pulmonary embolism. If the criteria is positive, then we have to go for the D dimer. Normal D dimer, no embolism. If the D dimer is high, then we have to go for CT angio. It may be normal, it may be abnormal. If normal CT angio, no pulmonary embolism. If the CT angio is abnormal, then we have to treat as a pulmonary embolism. And if the Wells or Geneva score is 2 to 4, then moderate risk of pulmonary embolism, definitely you have to go for D dimer. No need to do the pulmonary embolism rule out criteria. If D dimer is normal, P is ruled out. If abnormal D dimer, CT angio again has to be done to see whether there is embolism. And in high risk cases, definitely we have to do, no need to do D dimer test, you have to go for directly CTPA. Once the pulmonary embolism is diagnosed, then again you have to stratify the risk of the patient, whether he is in high risk or low risk or intermediate risk. It is a PC score, that is pulmonary embolism severity index, and one is modified PC score. In this, you see the age in years, altered mental status, systolic blood pressure less than 100, history of cancer, arterial oxygen saturation, temperature less than 36. All these parameters are there, and with the age you have to add these parameters, and the stratification is accordingly. If the score is less than 65, class 1, very low risk of complications, and if it is 65 to 85, it is class 2, low risk of complications. Class 3 is intermediate risk. 86 to 105, class 4 is high risk. 106 to 125, and class 5 is very high risk. It is more than 125. And in modified PACE score, there will be 1 points. If the point is 0, then there is definitely low risk, and more than 1 point is high risk. That is modified pulmonary embolism severity index score. P classification can be done on the basis of hemodynamic stability. If there is hypotension, needing vasopressors, and systolic is less than 90 and less than 40 of the baseline for at least 15 minutes, that is massive pulmonary embolism. Submassive pulmonary embolism is without hemodynamic instability and non-massive pulmonary embolism. So diagnostic test, accordingly, what we can do in non-massive pulmonary embolism, CTPA can be done and ultrasonography can be done. And if we see the symptoms of DVT, submassive pulmonary embolism, CTPA and echocardiography can be done. And massive pulmonary embolism, definitely echocardiography is the choice, because in massive pulmonary embolism, you cannot shift the patient to do the CTPA. So what are all the treatment protocols? If patient is having massive pulmonary embolism with hemodynamic instability, there is high risk of death. And if already patient is in cardiac arrest, thrombolytic therapy or embolectomy is the choice. How to do thrombolysis? By using streptokinase or even altiplase. Altiplase 100 milligram IV within 2 hours, or streptokinase 2.5 lakhs units loading dose within 30 minutes, then 1 lakh unit per hour for 24 hours in continuous infusion. And anticoagulation therapy should be started concomitantly in all the cases, whether it is massive pulmonary embolism or submassive or low risk of non-massive or asymptomatic pulmonary embolism. In all these cases, anticoagulation treatment has to be started at the earliest. So what are the contraindication of the thrombolysis, patient having any hemorrhagic stroke or intracranial tumor, ischemic stroke within 3 months, and any major history of surgery, trauma within 3 weeks, head injury, platelet count less than 1 lakh, active bleeding and bleeding diaphysis, definitely we have to avoid thrombolysis. So other treatment modalities are catheter-directed thrombolysis, catheter in patient with high risk of bleeding, and to disrupt the thrombus while spraying the thrombolytic into the substance of clot, direct thrombolysis. In arrest or peri-arrest situation, use of thrombolytics is often considered, as I told, and after infusion of anticoagulant, you have to monitor the APTT, and the target APTT will be around 40 to 60, that is 2 times of normal, and unfractionated heparin or Clexane can be used. And for iliofemoral DVT, catheter-directed thrombolysis can be done. So it is a flow diagram showing the treatment modalities. If there is acute pulmonary embolism, you start with anticoagulation, that is with heparin or fondaparinux, unfractionated heparin, whatever the choice according to the patient profile. Then see whether there is hemodynamic stability or instability, that is systolic blood pressure less than 90 or for more than 15 minutes, or repairing vasopressure. If there is no hemodynamic instability, then positive PC score or CT angio with abnormal RV and increase the BNP or a troponin. Then if it is yes, so it is intermediate risk pulmonary embolism. If it is no, then low risk pulmonary embolism. Means if there is in echo and CT angio, there is presence of embolism, that is low risk, and there is no increase in the tropi and proBNP, it is very low risk. So accordingly, you have to treat. And only anticoagulation is the need of R in low risk. If it is intermediate risk, that is CT angio positive, and in echo also you are finding the typical P changes, and with tropi, high proBNP, then intermediate risk pulmonary embolism. It is submassive pulmonary embolism. So again, you have to go for the pulmonary embolism team consultation. RV abnormal or and high troponin I and proBNP. It is intermediate risk. If there is absolute contraindication to thrombolysis, consider catheter-directed thrombolysis or surgical embolectomy. If there is no absolute contraindication of thrombolysis, consider catheter-directed thrombolysis or reduced dose streptokinase therapy. And if the RV is abnormal or high tropi or proBNP, one of these two things, either RV abnormal or tropi and proBNP is increased, then intermediate risk, then anticoagulation is the treatment as in low risk. Then coming to the massive pulmonary embolism, if the systolic blood pressure is less than 90, then definitely it is high risk or massive pulmonary embolism. You have to search for the pulmonary embolism response team consultation. And if there is contraindication to thrombolysis, absolute contraindication, you can go for directly catheter-directed thrombolysis or surgical embolectomy. And if there is relative contraindication, consider catheter-directed thrombolysis or reduced dose streptokinase therapy. And then if there is no contraindication, full dose systemic thrombolysis. And you have to see after all these things, if there is still hypotension and refractory shock, we have to consider the mechanical support like right ventricular assist devices or ECMO. So things to remember, we have to first risk stratify whether it is high risk or intermediate risk or low risk. In all these cases, anticoagulation will be started from first. Then if it is low risk, only that is needful. If intermediate risk, whether the RB is abnormal in both the cases, then whether biochemical parameters are there. If biochemical parameters have also been raised, then it is intermediate high risk. You can see for the catheter-directed thrombolysis or surgical embolectomy or directly reduced dose systemic thrombolysis. And in high risk cases, the drug of choice means the choice of management is thrombolysis. If there is absolute contraindication, you can go for catheter-directed thrombolysis and surgical embolectomy. Surgical embolectomy is actually done in patients where the embolus is in the central part of the bronchus. Sorry, in the pulmonary artery. If the peripheral part is occluded, means the segmental or subsegmental arterioles are occluded with the embolus, there is no role of surgical embolectomy. Only catheter-directed thrombolysis can be done. So anticoagulation, you can use unfractionated heparin, low molecular weight heparin, your oral anticoagulants, warfarin. And in patient all amenable to all these things, and still there is pulmonary embolism, IVC filters can be used. And those patients who are having anticoagulation contraindication, with or without pulmonary embolism, filters are used. And surgical embolectomy is done in some patients where systemic thrombolysis cannot be done. So this is a table showing the agents that can be used for anticoagulation. First is unfractionated heparin, used IV. It has renal clearance. Half-life is 1.5. Low molecular weight heparin, definitely renal clearance is high, so should be avoided in renal failure patients. Fondaparinux also, renal clearance is high, should be avoided. Vitamin K and oral anticoagulants like warfarin, it is negligible renal clearance. It should be started in low risk and intermediate risk pulmonary embolism. It should be started immediately along with anticoagulation, IV anticoagulation, so that within 5 days we have to see the levels and we have to convert it to the oral anticoagulants. New drugs like apixaban, edoxaban, rivaroxaban, these are all used nowadays for long-term anticoagulation in provoked or unprovoked pulmonary embolism. And dabigatran can also be given in patients who are high risk. So duration of anticoagulation in the pulmonary embolism is unprovoked. There is indefinite period of anticoagulation to continue. In surgically provoked cases, 3 to 6 months of the anticoagulants are required. And that DVT that requires medical illness, 3 months of anticoagulation is required. Cancer patients, as long as cancer is active or under treatment. So what is the sequelae of DVT? Non-fatal. Recurrent DVT can occur. Means there will be recurrence of DVT in some time, and post-thrombotic syndrome is there. Chronic thromboembolic pulmonary hypertension develops in these patients, and sometimes fatal pulmonary embolism can also occur. So how to prevent? All ICU patients should have adequate assessment of pulmonary embolism by different probability testing. Then pharmacological low molecular weight heparin or unfractionated heparin as soon as you diagnose the pulmonary embolism. Mechanical approaches like graduated compression stockings and intermediate pneumatic compression devices are there in patient where the risk of bleeding is there. Thank you.
So that is very good presentation, sir. Vilas, sir.
Yes, yes.
This is a very nice presentation. So we have to focus on pulmonary embolism rule out criteria as well. Apart from the ruling criteria, we have to focus on rule out criteria as well after doing Geneva criteria, right, sir?
No,
Before going
rule out criteria is for low risk patients. In high risk patients,
exactly,
we have
exactly.
to see.
For example, if Wells and Geneva has come, the scores were low, we have to go for pulmonary embolism rule out criteria. Then we have to proceed.
Yeah.
That is one. And now of these days, the catheter directed therapy has gained a lot of significance. Actually. As you
Yes,
said,
because of there
so
are a lot of contradiction of systemic thrombolysis. So
exactly.
mostly you have to go for catheter directed therapy.
There were few case reports shown that catheter directed therapy was used in case of cardiac arrest as a part of resuscitation. So this is the area of interest now. Okay, sir.
If patient is having cardiac arrest due to pulmonary embolism, you can directly
Yes,
go for systemic thrombolysis, and even you can use the VA ECMO.
exactly. Okay, okay.
Very arrest.
Yes.
Yeah.
So is there any role of CDT here, sir? Means there is no availability of VA ECMO. So after giving systemic thrombolysis,
CTPA.
the patient. No, sir. Catheter directed therapy. Catheter directed therapy.
No.
After giving
If
thrombolysis.
in arrest condition, definitely systemic thrombolysis, and still patient in shock, you cannot do all this catheter direct thrombolysis and all. Directly you put for VA ECMO.
Okay, okay.
Massive pulmonary embolism, ECMO is the choice.
Thank you, sir. So without wasting much time, I want to welcome the next speaker, Dr. Satyajit Chaudhary. He will be speaking about cardiac arrhythmias. After you, Sir Satyajit. In case of any queries, kindly post in the chat box. The speakers will be replying. Thank you.
Is it visible?
Yeah, it's visible, sir, and you're audible. You can share yours.
Okay. Good evening, everyone. So we'll be discussing something about arrhythmia, which is a very vast topic. So definitely it's not possible to cover each and every bit. We'll try to touch the must-know areas, and I've tried my best to make it as simple as possible. Okay. Arrhythmia is defined as irregularity in either heart rate or rhythm, and patients admitted to the ICU are at increased risk for arrhythmias. Cardiac arrhythmia are common in ICU, and it can be either an initial reason for admission itself, or sometimes it is the consequence of some other medical condition is developed during the treatment period, during the stay of the patient. There are major exacerbating and contributing factors are present, and management of arrhythmia requires the treatment or management of the contributing factors. Before going to arrhythmia, we should know something about the cardiac conduction system. Electrical signals arise in the SN node and stimulate the atria to contract. They then travel to the AV node, which is located in the interatrial septum. After a delay, the stimulus diverges and conducts through the left and right bundle of peace to the respective Purkinje fibers on each side of the heart. So this is a flowchart. This is a diagram showing how the impulse gets originated in the SN node and it travels through to the AV node. Then through bundle of peace, it reaches the Purkinje fibers on each side of the heart. So any irregularity in this conduction system or pathway leads to arrhythmia. Now, how these are getting controlled or regulated? Mainly through neural and humoral regulation and present. Neural regulation is through either parasympathetic or sympathetic nerves. Parasympathetic is taken care by mainly vagus nerve. It slows down the pacemaker cells, slows the SN node, AV node, but it has got minimal effect on Purkinje system. Similarly, the sympathetic nerves, they accelerate the pacemaker cells and facilitate AV node conduction. They also have minimal effect on Purkinje system and bundle of peace. And humoral factors that regulate these conduction include catecholamines like norepinephrine, epinephrine, renin-angiotensin aldosterone system, vasopressin, ANP, and endothelin. Now, what are the risk factors for developing arrhythmia in an ICU patients? There are certain risk factors like male, gender, age, above 70 years, cardiac diseases, underlying cardiac diseases like valvular heart disease, heart failure, CAD, pulmonary diseases like asthma, thyroid disease, or critically ill patient with Apache score very high, volume fluctuations, electrolyte imbalance, metabolic derangements, and vasopressor use on weight. And arrhythmias are broadly classified into two types, tachy and brady. Now, what are the diagnostic approach? How will approach a patient arrhythmia? First, we should determine the urgency, whether the patient needs immediate attention for his arrhythmia or it can be managed at the later stage after stabilizing the patient. So, if there is hypertension, ischemia, heart failure, altermentation, and other signs of hypoperfusion like developing hypoxia or decreased urine output, then it needs urgent attention for the treatment of arrhythmia. For that, first we need to identify the cause. So, what are the common causes that lead to newly developed arrhythmia are hypoxia or hypoventilation, hypokalemia or hypervolemia, dyselectrolytemia, potassium magnesium, metabolic acidosis, hypothermia, coronary ischemia, tamponade, acute pulmonary process like PE and pneumothorax, trauma, intoxication, or in certain cases, iatrogenic or mechanical stimulation with a central line or guideline. Now, understanding the mechanism of this tachy and bradyarrhythmia. Bradyarrhythmias are mainly due to decreased atomicity and impaired conduction that lead to either sinus bradycardia or arrest, and impaired conduction sometimes lead to heart block, complete heart block. Similarly, tachyarrhythmias are because of mainly increased automaticity, re-entry, and increased trigger activity. Now coming to bradyarrhythmia proper. So bradyarrhythmias arise from problems in impulse generation or impulse conduction. Diminished automaticity in the sinus node results in sinus bradycardia, and in more extreme cases, it leads to complete sinus pulse. Heart block is usually due to diseases in the AV node or Purkinje system, and the latter being associated with higher grade of AV block. Now, what are the various types of bradyarrhythmia? First is fast degree, second degree, third degree. Fast degree heart block or fast degree AV block. Here, the peer interval in ECG, what you'll find, the rhythm is normal. Here, the peer interval increases, and usually it exceeds more than 200 milliseconds. And every P wave is followed by a QRS complex, as seen in the sample ECG given, and the peer intervals may be prolonged to such a degree that P wave sometimes gets buried in the T wave or even QRS complex. And fast wave block is commonly associated with increased vagal tone, occasionally due to drug effect like digoxin, ischemic heart disease, and rheumatic fever. Usually doesn't cause any symptom and requires no treatment. If associated with digoxin, then we should obviously stop the drug. Now coming to second degree AV block, is characterized by intermittent failure of the AV conduction. And again, it is classified into two types, Mobis type 1 and type 2. And here we should remember that second degree AV block can occur in SVT also. However, the conduction block is a physiological protective mechanism in those settings. So Mobis type 1 or rank back block. Here the delay in AV conduction increases with each atrial impulse until an atrial impulse fails to conduct. Means gradually the interval gets increased, and at what point one bit will be absent. So there is progressive lengthening of the peer interval over successive cardiac cycles, and culminating in a non-conducted period. That is period not followed by a QRS complex, so resulting in a missed wait, and is common in fit healthy people in the presence of high level of resting vagal tone. Here in the sample ECG, you can see the first cycle, the peer interval is 260 milliseconds, then it is increasing to 80, 320, and the fourth cycle, the QRS complex is altogether absent. The condition is generally benign and doesn't carry the adverse likelihood of progression to complete AV block. Sometimes it may occur with infarction or infarction. So treatment is rarely necessary unless symptomatic treatment is not required. Now, Mobis type 2, there is intermittent failure of conduction of atrial impulse to the ventricles without preceding increase in the peer interval. So the ratio of conducted to non-conducted atrial impulse varies. For example, for every second or fourth atrial impulse may be conducted, so leading to 2:1 or 4:1 AV block. So the lesion causing type 2 is usually situated in the bundle of his, and it's always pathological. We cannot ignore this condition. ECG showing peer intervals remains constant prior to the block period, and there is always a constant P to QRS wave ratio. The P waves are the 2, 3, or sometimes 4 times more frequent than the QRS wave, depending on the type of block. So you can see in this ECG, 2:1 block, every alternate P wave is not followed by a QRS complex. So it is likely to be associated with a structural heart disease, and slower symptomatic ventricular rates may require pacing also. AV blocks may be intermittent or persistent. The adverse prognosis relates to the frequency of progression to complete AV block. That is the issue. It's most of the time progresses to complete heart block, so it needs immediate treatment. Now, what is third degree or complete AV block? Here, the rhythm occurs when no atrial impulse are conducted to the ventricles, and there is complete dissociation between atrial and ventricular contraction. SL node continues to depolarize the atria, whereas ventricular activation depends on a standby escape pacemaker located below the block. It has no relation with the impulse generating in the SL node. The escape pacemaker may be close to bundle phase. In those cases, there will be a narrow QRS double pacemaker with 40 to 60 beats per minute, or it may be distal in the ventricular tissue where the rate may be 20 to 40 beats per minute. If no ectopic escape pacemaker emerges, then ventricular assistance will occur, resulting in Stokes attack or death if episode is prolonged. Toxicity points may also occur associated with this bradycardia. And here the ECG shows normal regular period completely dissociated from the QRS complex. And QRS rate is always significantly slower than the PVF rate and maybe very slow at times. Idiopathic fibrosis of the conduction system is the most common cause of this condition. Other causes like MI, valvular heart disease, cardiac surgery, and a congenital form of complete heart block may also lead to this condition. Cardiac pacing is usually required to increase the heart rate and cardiac output. And congenital forms often have a relatively fast escape ventricular rate, and patient may remain asymptomatic for many years before it is getting diagnosed. In this sample chart, we can see that PUF rate is 90 per minute, and there is no relation between P and QRS, and the QRS rate is here only 36 per minute. Now, what is sixth sinus syndrome? This consists of a number of sinus node abnormalities, including inappropriate sinus bradycardia, SA block, or sinus arrest. When sinus bradycardia or SA block occurs, junctional escape breathing are common. There may also be abnormalities of epiconduction leading to bradycardia, tachycardia syndrome, or paroxysmal AF or AF flutter, and alternating with bradycardia. The bradycardia associated with sixth sinus syndrome may result in syncope or near syncope. This is not associated with structural heart disease, but may occur with ischemic and congenital heart diseases. How will treat this condition? Cardiac pacing is usually required to control bradycardia symptoms. Sometimes we need to use atropine and low dose of isoproterenol to increase the heart rate. And bradycardia tachycardia syndrome may require both pacing in case of bradycardia and use of antiarrhythmic drugs if the condition is tachycardic. So anticoagulation needs to be conditioned if episodes of AF occur in between. This is a sample ECG showing bradycardia tachycardia syndrome. I can see atrial fibrillation of flutter, and in between there is complete heart block. Now, few slides about bundle branch block. First, right bundle branch block. If the right bundle branch block, the normal rapid coordinated depolarization of the right ventricle is lost due to conduction block in the right branch of bundle piece. ECG is showing wide QRS, usually more than 120 milliseconds, and QRS morphology is typically in separate in the leads B1 and B2. This is the diagnosis. This results in two R waves, with the smaller of the R waves smaller and the larger R wave is called capital R. So classically it is called RSR pattern in B1 and B2, and broad S wave in left ventricular leads, especially 1 and B6. In B6, the R wave is greater than any S wave present. So here you can see this is the classical M pattern or RSR pattern. RBV may be sometimes a normal variant, but may occur with massive pulmonary embolism, right ventricular hypertrophy, ischemic heart disease, and congenital heart disease. So we cannot ignore it. Now, left bundle branch block is delayed and anomalous activation of the interventricular septum from right to left. Here ECG is showing again wide QRS, and B1 is the in B1 the characteristic morphology shows an small r capital S or capital Q S pattern. In B6 there are primary and secondary R waves, so R dash pattern, often resulting in insipid or vacuum morphology. And the QFs are never seen in the alveolates like B4 to V6. Here, you should note that myocardial infection cannot usually be diagnosed in these conditions if the patient is already having LVB. and it is often associated with heart disease like coronary artery disease, cardiomyopathy, or left ventricular hypertrophy. LVV diagnosis of MI difficult makes the diagnosis difficult, and the development of a new LVV fulfills the ECG criteria of acute infarction. Now, who are the patients who should get a pacemaker? If the patient is symptomatic, first thing, symptomatic bradycardia, you should always aggressively treat, like syncope, pre-syncope, or excessive intolerance there that can be attributed to bradycardia. Symptomatic second or third degree epiblock, congenital third degree epiblock with wide QRS complex, advanced epiblocks after cardiac surgery, recurrent type 2 second degree epiblock after MI, and third degree epiblock with wide QRS or bundle branch block. Summarizing the treatment of bradycardia, depends on mainly the presence or absence of symptoms and hemodynamic stability. If the patient is asymptomatic, treatment is not indicated. If the patient is unstable hemodynamically, then we have to rapidly increase the heart rate by using atropine. And in MI setting, it should be used with cautiously. And in heart transplantation, use of atropine may not be helpful because of paradoxical denervated heart leading to paradoxical worsening outcome. If bradycardia and symptom persist, then we may need IV infusion or temporary pacing. In hemodynamically stable patients, we should evaluate for systemic conditions associated with bradycardia. In addition, the following things should be kept in mind, like removal of the offending medications that may be causing bradycardia, correct the metabolic derangements, and avoid triggers with vagal mediated responses. Now coming to tachyarrhythmias. So it's a broad classification. If heart rate is above 100, we should see in the ECG whether it is a narrow QRS or wide QRS. If QRS is less than 0.12, then we should see the RR interval. If it is irregular or regular, if it's irregular, then monomorphic atrial tachycardia or atrial fibrillation. If it is regular, it may be sinus tachycardia, atrial flutter, or fibrillation, or evinodal reentrant tachycardia. If there is wide QRS, then again regular or irregular RR interval. If regular, then maybe VT or SBT. If prolonged, maybe congestion. If irregular, then there may be irregular supraventricular tachycardia with prolonged AV congestion. Tachyarrhythmias mainly have three general mechanisms, as we have studied, mainly increased atomicity, re-entry, and triggered activity. Increased atomicity can occur in the atrium or avenue or within the ventricle. Re-entry is the most common mechanism for tachyarrhythmias for re-entry to occur. Two pathways with different conduction properties must exist, and it may be anatomically oriented in such a way as to form an electrical circuit, as we'll see in the next slide. So, re-entry can occur around the anatomical barriers such as CAT or by utilizing anatomically distinct pathways such as the slow and fast pathway of the epidural. Here in the picture, we can see how there are two pathways being explored that leading to re-entry tachycardia. So the first impulse travels forward on the anterograde and it can be proceed retrograde up to the second pathway again of the re-entrant loop, which will now be recovered from it and ready to conduct the impulse. So the impulse can create an endless loop of re-entry while simultaneously activating the adjacent myocardium. First, we will discuss about supraventricular tachycardia. It's a tachycardia that requires atrial or AV nodal tissue for initiation and maintenance. These are usually conducted rapidly through the bundle branch so that QRS complexes are narrow. All narrow complex tachycardia are usually supraventricular tachycardia, and wide complex tachycardia are usually ventricular. However, supraventricular may be wide complex in the setting of bundle branch flow and pre-excitation. Now, what is the classification? Broadly, atrioventricular node dependent and another is AV node independent. Node dependent and AV node re-entrant tachycardia. So here what happens? Re-entry within the AV node, and another is AV re-entry tachycardia, where re-entry includes the accessory pathway between atria and ventricles, not the node dependent. Another one is accelerated idionodal rhythm. increased automaticity of AV node. And another AV node independent SBTs are at the atrial flutter, atrial fibrillation, unifocal atrial tachycardia, or multifocal atrial tachycardia. We'll discuss them one by one. First, AV node dependent SBT here. These are sometimes referred to as junctional tachycardia. Here, the re-entry circuit or ectopic focus involves the AV node or junction. And here, the blocking of AV node will definitely resulting in termination of this SBT, and this blocking can be achieved by either vagal maneuvers or drug like adenosine. And AV node independence, they are referred to as atrial tachycardia. Here, blocking the AV node is not going to help us. So it will only merely slow the ventricular rate. Now, avinodal re-entry tachycardia or AVNRT. Here, the re-entry tachycardia is confined to the AV node, as we discussed. ECG showing a regular narrow complex tachycardia, 140 to 220 beats per minute usually, with abrupt onset and termination. And here, the P waves are not usually observed, as most of the time they are buried in the QRS complex. This is a ECG showing AV nodal re-entry tachycardia. And here is a common arrhythmia that is not usually associated with structural heart disease. And the major symptom here is palpitation only. And treatment most of the time, vagal maneuvers will slow down its conduction and break this tachycardia. And if it fails, then we should use adenosine with the drug of choice 6 milligram. It can be repeated. If another 6 or 12 milligram can be given. Cardioversion is occasionally necessary when drugs are ineffective and when severe hemodynamic instability is present. And troublesome recurring episodes of AVNIT can be cured by also radiofrequency ablation. Here, the re-entry pathway consists of the AV node and an accessory pathway which bypasses the AV node leads to AV re-entry and tachycardia. The accessory pathway may be evident during the sinus rhythm with the ECG showing short PR interval, a delta wave, and a widening of QRS. The ECG is similar to AV and the length of re-entry circuit is however greater, and the accessory AV pathway is some distance away from the AV node. The ECG is showing AVRT, as you can see, the narrow QRS tachycardia at around 135 beats per minute. AVIT is similar to AVNRT, although anterograde conduction over the accessory pathway may be very rapid with WPW syndrome if F occurs. And treatment, most of the time, here the treatment is similar to AVNRT, like vagal maneuver adenosine. Here we should remember that verapamil should be avoided in WPW syndrome, as it may block the AV node, facilitating very rapid conduction to the accessory pathway. Prevention should be done with sotalol and flecainamide, and radiofrequency ablation of the acid pathway is usually curative. Now, multifocal atrial tachycardia or MAT is defined as an atrial rhythm with a rate greater than 100 beats per minute with organized discrete non-sinus period, having at least 3 different forms in the same ECG tracer. And irregular atrial rates usually 100 to 130, and 3 different PV morphologies are visible in the same trace, as we can see in the given diagram. And it is often misdiagnosed and inappropriately treated as atrial fibrillation. Rhythm occurs most commonly in critically ill elderly patients with COPD cor pulmonale. And theophylline has been implicated as precipitating cause and in most of the cases. Treatment, magnesium here is the drug of choice for MAT, and beta blockers are effective than diltiazem, but most of the time it is avoided because of their bronchoconstriction activity. And digoxin and cardioversion are ineffective here. And long-term control is best achieved with diltiazem. Now coming to atrial flutter and fibrillation, most important Coming to treatment, drug therapy has proven to be notoriously unsuccessful for atrial flutter. Large doses of AB blocks are often needed. So, although no drug will be reliably terminate flutter, but ebutilide and dofetilide have been shown to be most effective in pharmacological reversion. Flecainamide and procainamide may also be tried, and synchronous cardioversion, DC cardioversion with low energy, 50 to 100 joule, may also be tried. And here, radiofrequency ablation is most amenable to circuit ablation. Yes, is the coming to atrial fibrillation is the most common arrhythmia following sinus tachycardia we encounter, and mostly seen in case of post-cardiac surgery patient. Also, there is loss of atrial contribution to ventricular preload, contributing to normally that contributes to 25% of the ventricular preload. So that is gone, leading to hypotension and hemodynamic compromise. Loss of atrial activity in AF also contribute to atrial clot formation and thromboembolic episodes. These are various types of AF for classification. Paroxysmal AF when it terminates within or without treatment within 7 days of onset. Persistent AF when it is sustained for more than 7 days. Long-standing if it sustains for 12 months or 1 year or more. And permanent AF when the patient and clinician decide to stop further attempt to restore the rhythm. Coming to diagnosis, hallmark is the presence of irregular RR interval and loss of distinct PUL. And some cardiac atrial activity may be seen known as fibrillation wave. And management, mainly acute management 2 dimension. One is control of rate, another is control of rhythm. This is a ECG graph showing AF with no PUF and irregular RR interval. First, coming to rhythm control, done by electrical cardioversion, preferably in hemodynamic unstable patients with systolic hypotension. With synchronous cardioversion is done with 100 to 200 joules of pre-medication and sedation opioids may be used and always synchronized. Should not be attempted in case of digoxin toxicity or severe hypokalemia. First, they should be corrected. And pharmacological cardioversion may be achieved with ebutilide, and amiodarone is the most widely used agent. Dose, as we all know, 1 milligram per kg per hour for 6 hours, followed by 0.5 milligram per kg per hour for 60 hours. And drug therapy for rate control in stable patients, we can use beta blockers in low dose, esmolol, verapamil, and in unstable hypertension, patient, digoxin, amiodarone may be used. However, the rhythm control, if possible, appears superior in patients with LV dysfunction with both amiodarone and dipeptide, reducing mortality when sinus rhythm is achieved. And if AF is persisting for more than 48-hour duration, then we should consider therapeutic anticoagulation for at least 3 weeks before cardioversion, and it should be continued for 4 weeks after cardioversion. Then atrial fibrillation ablation therapy is indicated for failed medical treatment cases. If surgical myectomy is required, then Mays procedure, left atrial appendage excision should be performed. Now coming to ventricular tachycardia, is defined as 3 or more ventricular ectopic beats at a rate greater than 130 beats per minute. It sometimes may exceed 300 beats per minute. VT lasting for 30 seconds is considered to be a sustained VT. May not cause any symptoms, but associated with increased mortality in certain patients like MA patients. Maybe monomorphic or polymorphic. Monomorphic is usually associated with structural heart disease or electrolyte disturbance, old myocardial scar, post-infarction, or cardiac surgery. Usually, a Brugada criteria is used to distinguish between BT and SBT. These are the ECG ECG readings showing monomorphic ventricular tachycardia. Here, the morphology is similar in all QRS complexes. Treatment is by DC shock with 100 joule, and if patient is hemodynamic unstable, and if stable, then antiarrhythmic drug trial may be tried. Implantable defibrillators can recognize and automatically terminate a BT by rapid ventricular pacing. And catheter ablation is being increasingly used in acute setting for VT storm patients. What is polymorphic ventricular tachycardia? Is either with a normal QT interval or with a prolonged QT interval when it is known as dorsal depointis. Here the patients are usually hemodynamically unstable, unlike in monomorphic ventricular tachycardia, and needs urgent synchronized DC cardioversion with a higher energy of 200 joule. And MI should be treated expeditiously in patients with polymorphic VT and normal QTC. Amiodarone and beta blockers are effective for the suppression of arrhythmia. In case of tertiary depointis, the focus should be to identify and correct the underlying cause of prolonged QT if possible. Here we should consider iron magnesium 1 to 2 gram over 2 to 20 to 30 minutes. This arrhythmia has QRS complex at 200 beats per minute with change in amplitude axis so that they appear to twist around the baseline. Dorsal depointis usually has prolonged QT during sinus rhythm and U waves are often present. Now, here it always causes hemodynamic collapse, loss of consciousness, and death if not immediately managed. The patient recited from BF about 20 to 30%, they sustain AMI and 75% of coronary artery disease. So it's a medical emergency, immediately it should be treated. And ECG shows irregular waves of varying morphology and amplitude. Management is like in SLS protocol, CPR should be started immediately and shock given, and simultaneously the underlying cause should be treated. Summarizing, so first we should determine whether the patient is compromised by the arrhythmia or opposed to underlying condition. Then aggressively manage the life-threatening arrhythmias as per SLS guidelines. Determine the nature of arrhythmia, what I'm treating, and determine the underlying cause and try to correct those causes first. Then determine appropriate drug therapy based on clinical condition of the patient. Thank you.
That's a very nice
That
presentation,
was,
sir.
we'll try to answer them. Thank you.
Yeah, that's a very nice presentation. So, multifocal atrial tachycardia is the one which should be differentiated from atrial fibrillation because cardioversion won't act on that. That is the basic thing, right, sir?
Yeah.
So that is the reason which mandates us to diagnose multifocal atrial tachycardia. That is the point to be taken for today. So without any delay, I want to welcome Dr. Rupali Patnaik, ma'am, Associate Professor, IMS in the Department of Critical Care Medicine, IMS in some hospital, to talk on rhabdomyolysis. Ma'am, off to you, ma'am. Please start.
Hello, very good evening everybody. Am I audible?
Yes, ma'am, you're audible. Please proceed.
Basically, two topics to discuss. It's renal tubular acidosis and rhabdomyolysis both. Okay. So we'll first talk on renal tubular acidosis, then on rhabdomyolysis. Maintenance of acid-base homeostasis is major function of the body. It is accomplished by intracellular and extracellular buffering mechanism and exhalation of carbon dioxide through respiratory system and acid-base by the kidneys. So renal tubular acidosis develops as a consequence of impaired urinary acidification and is characterized by normal anion gap metabolic acidosis. It is RTA, it's linked to normal anion gap metabolic acidosis. There is impaired urinary acidification. Okay, I'll discuss the types where the pathophysiology is different. It occurs when the kidneys are unable to adequately reclaim filtered bicarbonate or secrete sufficient amount of hydrogen ions to maintain the acid-base homeostasis. The kidneys are basically major role is to maintain the acid-base function. They either maintain this by reabsorbing bicarbonate or secreting H+. So in the RTA, there is abnormalities with these things. That is either in the absorption of bicarbonate that leads to acidemia, and there is decreased excretion of H+. Okay, that leads to accumulation. These are the main pathophysiology abnormalities there. Docker is one of more defects in the tubular transport of H+ or bicarbonate. Types. It occurs mainly in patients with normal or mildly decreased GFR and those in CKD patients also. It's cause of hyperchloremic normal NNCAP metabolic acidosis. Loss of serum bicarbonate leads to retention of chloride so that NNCAP is maintains normal. Okay, there is loss of bicarbonate and chloride is gained. So 3 types of RTA mainly, type 1, type 2 and type 4 basically. Type 3 is there but is very rare. It is having features of both the proximal and distal. So it is like very rare. We discuss 3 types, type 1, type 2 and type 4. Type 1, okay. We'll first discuss the type 1. It is distal renal tubular acidosis is called type 1 RTA. It is abnormality with the distal tubule. That's why it is called distal. Okay, but type 1 is distal. I'll start with this case. It's a 34-year-old woman who presents with diffuse muscle weakness over several days. She also reports dry eyes and mouth over last several months. Lab analysis is suggestive of sodium of 141, fairly normal. Potassium 2.5 millimoles per liter, obviously low. Chloride is high here and bicarb is low. And an arterial blood gas suggestive of pH of 7.32, okay, like acidic picture, and PCO2 of 31. And serum creatinine is 1.4, urine pH is 6.8. Ultrasound imaging shows normal size kidneys with evidence of numerous calcification distributed throughout the kidneys. The patient is diagnosed to have type 1 or distal RTA, thought to secondary to underlying Sjogren syndrome. She is suffering from, okay, that's why dry mucous mouth and the conjunctiva, she is presenting Zika syndrome. And these are the distal RTA, the features she is having. Look, before going to the pathophysiology abnormality, first we'll discuss what is the normal physiology of the distal tubules. Okay, the distal tubules here, it is the cortical collecting duct I am showing in this picture. Okay, the intercalated cells of the cortical collecting duct. Here it is the interstitium. Okay, towards the blood vessel. Okay, this is the basolateral membrane, and this is the lumen towards the lumen of the kidney. So this is the apical membrane, this is the basolateral membrane, this is the intercalated cells. Then the H plus is secreted in the lumen by H plus K plus ATPase. There are 2 forms. Here is the H plus K plus ATPase form. One is other is vacuolar ATPase transporter. These are present on the apical membrane. 2. This the green is like active transporters. Okay, and blue is like passive transport. So like these are the active transport forms: H plus K plus ATPase and the vacuolar H plus ATPase. This is responsible for H plus secretion into the lumen. So H plus is secreted into the lumen by this mechanism. The like here, so everybody is that carbon dioxide, water, and carbonic anhydrase enzyme will come into picture. Here, like this water, they divides into H plus and OH minus. The H plus is secreted by this forms, actively transported out to lumen. The OH minus form, it combines with carbon dioxide to form bicarbonate. Okay, this bicarbonate inside the cell is transported towards the blood vessel, to interstitium to blood vessel, and chloride is gained into the cell. Okay, it's carbonic anhydrase 2 enzyme removed by this bicarbonate produced is removed by through the basolateral membrane by this AE1. Okay, the transporter, the resulting bicarbonate transporter, this is, and this lead to chloride gain by conductance challenge in the basolateral membrane. Luminal K plus transported into cells via this, the luminal K plus, they are then transported into the cells. Okay, like here bicarbonate comes out, chloride gains into the cell, and this chloride is exchanged with the potassium basically. Okay, this is the normal physiology. What happens there in the distal RTA? The distal RTA, here I am showing the red cross marks. There is the pathologic abnormalities. Okay, the basically abnormalities with these transporters, which I told, that leads to impaired H plus secretion through the decreased net activity of these pumps, that H plus ATPase and H plus K plus ATPase. Okay, or increase H plus permeability in the luminal membrane, also gradient defect. Okay, either increase H plus permeability and there is inactivation of these pumps. This lead to less H plus in the lumen. Okay, less H plus secreted into the lumen, so that they are retained back. They are retained in there and they are going to the they are not secreted. They are preserved, that lead to acidosis. The patient with distal RTA are unable to acidify their urine despite severe metabolic acidosis. Obviously, they are unable to excrete this H plus. Okay, here shown in this form, that's lead to accumulation of H plus, and that is acidemia. Distal RTA is correct by impaired urinary acid secretion and evidence of kidney potassium wasting with normal and minimally reduced GFR and persistently alkaline urine. Obviously, when there is abnormality in this sperm, the potassium which is absorbed in with the exchange with the chloride and absorbed through the vessel, they are also impaired. This lead to hypokalemia. Patient with distal RTA often present symptoms leading to hypokalemia like polyuria, polydipsia, ECG abnormalities, neuromuscular weakness mainly, and urinary concentrating disabilities. Distal RTA is a risk factor for nephrolithiasis and nephrocalcinosis due to hypercalciuria and hypocytruria combined with persistently alkaline urine pH. Okay, they are not secreting H plus into the urine. That is into lumen means it's into urine. That leads to alkaline urine pH. That alkaline urine pH lead to nephrolithiasis and nephrocalcinosis. Hypercalciuria and hypocytruria, that is less citrate and more of calcium is being excreted. That leads to kidney stone formation. Calcium stone formation. Clinical presentations like children, they present with fatigue, failure to thrive, and growth retardation rickets. Distal RTA is caused by impaired distal acidification of urine due to reduction in net H plus secretion in the distal nephron, resulting in impaired bicarbonate regeneration. Also, there in the picture also that H plus secretion only lead to the OH minus that remain that form combined with carbon dioxide to form carbonic anhydrase with 2 enzyme lead to bicarb regeneration. There is also impairment of bicarbonate regeneration that further leads to acidemia. Patient with distal RTA typical develop hyperchloremic, hypokalemic, metabolic acidosis with normal anion gap. Then comes the proximal RTA. The case is like 65-year-old male. He presents with back pain and unexplained anemia. Upon evaluation, following lab findings like sodium is fairly normal, potassium is low, 3.4, bicarb is less, 18, and chloride is 108 millimoles per liter. Glucose is 104, creatinine is 2.2, and total protein is 10. It's high. Arterial blood gas suggestive of pH of 7.35 and PCO2 of 33. It's like acidic picture. The urine analysis shows positive 1 glucose and urine pH of 5.5 less. Patient is diagnosed with multiple myeloma complicated by evidence of proximal RTA in association with generalized dysfunctional tubule. Like Fanconi syndrome, it is like proximal RTA is associated with other abnormalities. Okay, it is the most common cause here in mainly pathologies is the multiple myeloma, one of the cause which lead to proximal RTA. Okay, I'll discuss in detail the proximal RTA after this step. Coming to normal physiology, what happens in the proximal RTA? Proximal RTA, it is called proximal, but it is disorder there in the proximal tubule, PCT, proximal convoluted tubule. What is maximum bicarbonate absorption there in the PCT? In the distal RTA, there is defect in the H plus secretion of the distal tubules. Here, there is defect in the bicarbonate absorption of the proximal tubule. Okay, the bicarbonate reabsorption, what is normally how it happens in the proximal tubules. Here it is the proximal tubule cell and like same interstitium, this is the basolateral membrane, it is the apical membrane, it is the lumen, and it is the blood vessel. Hydrogen ions are secreted in the lumen by apical Na plus H plus exchanger 3. Okay, this is the Na plus H plus exchanger. The hydrogen ions are they are secreted into the lumen and sodium in exchange with the sodium. The apical carbonic, in the apical membrane, there is carbonic anhydrase enzyme, the carbonic anhydrase 4, that catalyzes the reaction between the H plus secreted and there is bicarbonate to forms the carbonic acid, which again diffuses into carbon dioxide and water. The carbonic acid that rapidly dissolves to water and carbon dioxide. That carbon dioxide is diffused back across the cell to the apical membrane, where carbonic anhydrase 2 here is the enzyme that catalyzes reaction with the intracellular OH minus. The OH minus ion is there. It combines with carbon dioxide diffused here to form the carbonic acid, to form the bicarbonate. The bicarbonate is transported across the basolateral membrane by, this is the co-transporter, one of the co-transporter, which leads to bicarbonate reabsorption. Bicarbonate absorbed along with the sodium. Okay, this is the co-transporter. What happens there in the this defect in the proximal RTA? Okay, like here mainly bicarbonate absorption occurs with this mechanism in the PCT's main mechanism is bicarbonate absorption. Others is like Na plus K plus ATPase is there, that is for sodium is to the vessels and more potassium into the cell. These are the abnormalities places where there abnormality in the proximal RTA, proximal tubular dysfunction, that is Defect in the bicarbonate reabsorption. Okay. Here it is the abnormality in the proximal tubule due to either impaired bicarbonate transport across the basolateral membrane. It is either in the transport of bicarbonate in the basolateral membrane, here in the picture, or inhibition of carbonic anhydrase enzyme. This carbonic anhydrase 4 and carbonic anhydrase 2 are the enzymes. The 4 in the luminal membrane that leads to that formation of bicarbonic acid, and again by carbonic anhydrase 2 enzyme, which again leads to formation of bicarbonate ion. Okay, this generation of bicarbonate is either defective, okay, or there is transport of bicarbonate carbonate is defective in the proximal RTA. So isolated proximal RTA is defect in the reabsorption of filtered bicarbonate in the proximal tubule. The threshold for serum concentrated bicarbonate reabsorption is normal 25 millimoles per liter. Here it is reduced, leading to delivery of larger quantities of filtered bicarbonate to distal nephron. And urinary bicarbonate also wastage. Obviously, there is less of absorption, that more will be delivered to distal tubules, and again there will be loss in the bicarbonate in the distal tubule wastage also. The reduction of serum bicarbonate. Obviously, there is less of absorption, more of wastage that lead to acidosis. Urine pH remains alkaline because of presence of urinary bicarbonate. There it is acidic. And here it is made of like alkaline because of urinary bicarbonate is more. And serum bicarbonate concentration decrease below the lower level when it is very less, then a new steady state is reached where all filtered bicarbonate will be reabsorbed. At this point, urine contains no bicarbonate and maximally acidic at this point. Okay, after the threshold is reached. These patients obviously present with hypokalemia and normal non-cap metabolic acidosis, and urine is acidic. Like these features are same as the distal RTA also. Proximal RTA lead to other features. There is whole of like proximal tubular defect, so that absorption of other electrolytes also affected there. That leads to hypophosphatemia, hypouricemia, euglycemic glycosuria, and proteinuria. Isolated proximal RTA, that is only bicarbonate reduction without abnormality of the transport, is rare. Mainly it is associated with other electrolyte abnormalities, and so the isolated ones are rarely like inherited ones only, carbonic anhydrase inhibitor, but and they usually present in the childhood, early childhood at growth retardation. Proximal RTA hypokalemia develops as a result of loss of proximal bicarbonate reabsorption. Obviously, increased urinary excretion of bicarbonate causes decreased intravascular volume, and that lead to renin-angiotensin system elevation, aldosterone elevation, and increase in potassium excretion. So this is the other reason. Then more of bicarbonate excretion leads to volume depletion, and ultimately that is the activation of the renin-angiotensin aldosterone system that leads to sodium retention and potassium excretion. More of potassium excretion leads to hypokalemia, which is there in proximal RTA. Proximal RTA occurs as an isolated defect in bicarbonate or typically associated with Fanconi syndrome, which is characterized by proximal tubular dysfunction, loss of phosphate, glucose, uric acid, amino acids, and low molecular proteins. Skeletal abnormality is mainly due to phosphate reabsorption, chronic hypophosphatemia, and renal phosphate wasting also occurs. Active vitamin D deficiency due to impaired conversion also. Osteopenia is one of the major feature of RTA. And drugs that can also precipitate RTA, like tenofovir, anti-HIV drugs, most important, and ifosfamide, valproate, and topiramate also culprits. Proximal RTA can occur secondary to metabolic disease like hereditary fructose intolerance and glycogen storage disease. And most common of acquired Fanconi in adult is like multiple myeloma. Here I shown this case is case of multiple myeloma, secondary CW, this proximal RTA. Then the third type is the hyperkalemic RTA, is the type 4 renal tubular acidosis. One case like 55-year-old male with long-standing diabetes referred for evaluation and treatment of diabetic nephropathy. His only medication is coxic. He is taking for his degenerative joint disease, which is COX-2 inhibitor, inoside. And physical examination is significant for blood pressure 146/92 and stress pedal edema. Lab findings is sodium 142 normal, and potassium is 5.7. It is high, hyperkalemic RTA. Chloride is 108, bicarb is 18. Less, serum creatinine is 2, and protein is 4.6. Arterial blood gas is suggestive of PCO2 30 pH of 7.5. So his primary care physician is reluctant to start either AS or ARB because of increased potassium concentration. That evaluation lead to diagnosis of hyperkalemic RTA in this case. It commonly develops in patients with diabetes or interstitial nephritis. characterized by disturbance in distal nephron leading to reduction in excretion of H plus and K plus in the collecting duct, result in hyperkalemic, hypochloremic, normal and gap acidosis. That is, it is main abnormality in the distal nephron that lead to reduction in excretion of H plus and K plus. Often they are asymptomatic, diagnosed during routine evaluation only, when symptomatic manifestation include muscle weakness, palpitation, and cardiac arrhythmia due to hyperkalemia. Diagnosed by presence of hyperkalemia, normal anion metabolism, and abnormal serum aldosterone level. Okay, so coming to pathophysiologic abnormality in the hyperkalemic distal ATA, main abnormality here is the aldosterone deficiency or resistance. Where the aldosterone acts, it is the distal convoluted tubule, the principal cells of the collecting duct. Like the principal cell, here it is the mineral corticoid receptor, where the aldosterone acts. This mineral corticoid receptor, what it is responsible for the sodium reabsorption basically to ENAC. This is the voltage gated sodium channel, so it lead to sodium reabsorption. The aldosterone mediated sodium reabsorption is the function of the mineral corticoid receptor here. Now, this is characterized by aldosterone deficiency and resistance, which lead to reduced sodium reabsorption by principal cells of the collecting duct and decreased transepithelial voltage, leading to diminished H plus secretion. This sodium reabsorption to decrease H plus secretion by intercalated cells and K plus secretion by the principal cells. Okay, obviously there will be like here in this picture, when there is less of sodium reabsorption because of this, then this Na plus K plus activase function will be lost. That is, it is like opposite of this occur. So that lead to increased potassium here, and also with this increase, when there is obstruction in this this pathway, when there is increased sodium, this is exchanged with the potassium also. This lead to less of potassium to going to lumen, and this is the potassium gated channel that more stays in this cell, and that is again it is coming back to here to interstitium, then to blood vessel. That's lead to hyperkalemia. It is caused by selective aldosterone deficiency or intrinsic defect in cortical collecting duct, aldosterone resistance. If the defect in the duct or there is decreased secretion. The hypoaldosterone cause reduced principal cell sodium reabsorption and decrease in transepithelial voltage in the cortical collecting duct, so that diminished excretion of H plus and K plus also, that leads to acidemia and hyperkalemia. Hyperkalemia is caused by various medications like potassium sparing diuretics, antibiotics also like trimethoprim, pentamidine, spironolactone, and these are the culprits. COX-2 inhibitors, ASN, ARP, and low molecular weight heparin also. Coming to in summary, the various defects in distal type 1 RTA is decreased distal acid excretion, increased H plus membrane permeability. Okay, less of acid secretion to the lumen. Proximal RTA, decreased reabsorption of the bicarbonate. In the type 4 RTA, reduced excretion of acid and potassium in the collecting duct. More of less of excretion of potassium and less of excretion of the acid. The symptoms here is like hypokalemia and the features of it, and nephrolithiasis or nephrocalcinosis because of hypercalciuria and hypocytruria. And growth retardation, failure to thrive. Here also same as features of hypokalemia, growth retardation, and vitamin D deficiency here also, and phosphate deficiency like in Fanconi syndrome it is associated with other ileocolite abnormalities. Occasional, this is mainly asymptomatic type 4. It occasional like cardiac arrhythmias and muscle weakness because of hyperkalemic features are mainly. Urine pH is like more than 5.3 here, less than 5.5, and less than, it is more of acidic here. And bicarbonate, almost acid. So potassium is here both cases low, here it is high. And NN gap is all cases are normal NN gap metabolic acidosis with hyperkalemia. Diagnostic stakes is positive urinary NN gap after ammonium loading test, and here it is like fractional excretion of bicarbonate is more, and urine pH is more after bicarbonate loading. Okay, defect in the bicarbonate reabsorption here. And here it is like urinary excretion of potassium is less, so urinary potassium is less of minus 40 millimoles per liter, or fractional potassium excretion is also less, and abnormal serum aldosterone level if you measure it is less. Coming to treatment, mainly increase citrus fruit and fluid intake in the, it is like distal RTA, proximal end. When all is like the patients with soda bicarbonate or potassium bicarbonate or potassium chloride, potassium citrate in patients with severe hypokalemia. Here in the proximal artery, alkali therapy, only potassium citrate. They usually get the potassium citrate syrups for that, and vitamin D and phosphate replacement. In the distal artery, treatment is a low dose fluorocorticoid therapy or loop diuretics, okay, for hyperkalemia, and the features of the treatment for hyperkalemia, potassium binders, bicarbonate, oral therapies, and all that. Then we'll discuss rhabdomyolysis. Should I proceed? Or questions people will putting on the chat box?
Yes, proceed.
That's what questions will be in the chat box. You can proceed. You can proceed.
Don't know. Okay. Rhabdomyolysis is basically caused by the rhabdomyolysis is there is lysis of the muscle cells. Okay, that is called as muscle cells lysis is called rhabdomyolysis. It's caused by breakdown and necrosis of the muscle tissue and release of intracellular contents into the bloodstream. Usually result from traumatic or non-traumatic injury to skeletal muscle. The skeletal muscle comprise almost 40% of the body mass. So that an insult can result in accumulation of cellular content that would eventually overwhelm the underlying elimination mechanism. Okay, that is the major abnormality here, because skeletal muscle contribute most of the body surface area, and insult leading to very much increased amount of accumulation of cellular contents. The rhabdomyolysis even detected in at the Bible Old Testament, where the use of hemlock hops they were using for toxin purpose for the migrants from the Egypt. Okay, that lead to features of rhabdomyolysis. Now, there will be intense muscle pain and even dark colored urine, dark tea colored urine. Okay, it's been documented from the era of Bible. And clinical presentation can vary from subclinical elevation of serum enzyme levels like creatinine kinase, LDH, and aspartate aminotransferase to acute kidney injury itself. Coming to etiology, yes, hereditary causes are there, like deficiency of glycogenolysis or glycogenetic pathway enzyme mark this disease, mainly for the cause of rhabdomyolysis. Or other acquired causes can be traumatic and non-traumatic. Traumatic leading to intense muscle exercise or direct muscular damage like cross injuries, accidents, RTA, natural disasters, earthquakes, bomb, frostbite, and electric burns also. And intense muscular exercise like patient presented status epilepticus, status asthmaticus, tetanus, acute dystonia, myoclonus, and intense military training also. These are the causes for intense muscular exercise that lead to rhabdomyolysis. Coming to non-traumatic causes can be ischemic like compression, thrombosis, obstruction of blood flow, like arterial embolism, sickle cell crisis, all that. Various drugs like statins, fibrates, cocaine, methadone, amphetamines. These are also culprits for this rhabdomyolysis, steroids and in high doses. And toxins like snake poisons, bee sting, spider bite, all these can also lead to rhabdomyolysis. Thermodependent syndrome like toxic shock syndrome, heat shock also. Metabolic diseases like hypothyroidism, decay, and all that also. Electrolyte disorders, hypokalemia, hypocalcemia, and hypophosphatemia, either major. Major is like an inflammatory myopathies like polymyositis or dermatomyositis, these patients, and various bacterial infections which involve the muscle with myositis and muscle involvement mainly that lead to rhabdomyolysis. Coming to pathophysiologic abnormalities, what happens leads to ischemia, intense muscular exercise, dependent syndromes, medicines, electrolyte imbalance, metabolic disorders, hereditary disorder, all these lead to decreased ATP production, and this leads to defect in the Na plus K plus ATPase dysfunction or calcium ATPase dysfunction. This leads to activation of sodium calcium exchanger. And all this leads to what is most final common pathway is the increase in the intracellular calcium. What is important? It's intracellular calcium. So these leads to decreased ATP production, the dysfunction of this membrane transporter. This is basically present in the sarcolemmal membrane that leads to increased calcium, intracellular calcium deposition. And also there is sarcolemmal membrane rupture directly. These are the causes like toxins, intense muscle exercise, trauma. This lead to direct damage to the sarcolemmal membrane. All this lead to increased intracellular calcium. This intracellular calcium increase lead to hypercontractility of the muscle cell, and also this increased intracellular calcium leads to activation of the phospholipase pathway and protease pathway. That also lead to activation, either hypercontractility, activation of the phospholipase and protease activation, and increased intracellular calcium lead to apoptosis also, increased mitochondrial calcium, that is mitochondrial dysfunction and apoptosis. Also increased calcium and reactive oxygen species is produced that lead to lipid peroxidation pathway and rhabdomyolysis ultimately. This is the main pathophysiologic abnormality starts with the increase in the intracellular calcium. The intracellular calcium leads to the cascade of abnormality. Rhabdomyolysis lead to release of toxic intracellular contents, capillary injury, edema, and rise in intracompartmental pressure, ischemia itself, which lead to further aggravates the rhabdomyolysis. Then is to inflammatory mediators and reactive oxygen, that is itself it's a vicious cycle. The release of toxic intracellular substance into extracellular space damage the regional capillary circulation, local edema, and migration of circulatory leukocytes to the lesion area. Edema increase the intracompartmental pressure and the leukocytes produce reactive oxygen species that ultimately leading to inflammatory and necrotic process. Then most abnormality in the rhabdomyolysis, threatened abnormality, is the development of acute kidney injury. The rhabdomyolysis leads to fluid sequestration and intravascular volume depletion, decreased renal perfusion for that, and activation of the various sympathomimetic effects, renin-angiotensin pathway, ADH pathway, and sympathetic nervous system pathway. Though all these lead to renal vasoconstriction. And also myoglobinuria in muscles, the myoglobin is released that leads to myoglobinuria, muscular injury lead to this myoglobin precipitated with TAM horseball protein of the loop of Henle that leads to tubular cast formation, and that lead to acute kidney injury. And release of heme moiety with myoglobinuria degradation, this lead to free radical formation, direct ischemia of the tubular injury. Either direct ischemia injury of the tubules, there is tubular cast formation with the myoglobin precipitated with the TAM horseball proteins, and there is decreased renal perfusion, activation of the systems leading to renal vasoconstriction. All that lead to AKI. Clinical presentation is wide. Typical triad is like muscle pain, weakness, and reddish brown urine. 50% of cases, pain is focused on central muscle groups like thigh and shoulder. However, more than half of the patients do not report muscular symptoms. The reddish brown color of urine is due to myoglobinuria and constitutes a powerful diagnostic element. In approximately half of the cases, and its absence does not exclude the syndrome. Okay, it's not like urine is not color is not tea-colored urine, then it is not rhabdomyolysis. Muscle stiffness and seizure has been reported as the most severe cases of rhabdomyolysis. General symptoms like malaise, fever, tachycardia, nausea, vomiting, these are present. In clinical examination, muscles may be swollen and sensitive during palpation, while changes in color of skin compatible with compression and necrosis. Various lab findings like increase in myoglobin, increase serum CPK muscle variant, okay, creatinine phosphokinase, like 3 isoenzymes are there in the muscle. One is like brain, other is like heart, MB and B most probably. So these this isoenzyme is mainly elevated of the CPK. This is more specific compared to CPK itself. Potassium is elevated, the muscle injury lead to phosphorus is elevated. There is obviously decrease in calcium and calcium phosphate adduct formation, hypocalcemia, and this potassium and phosphate is elevated. Uric acid is obviously elevated. There is acidemia, decrease in pH, carbonic anhydrase is increased, and these are various other parameters which are fine. Most important is like decrease in calcium, increase in phosphate, uric acid, and increase in potassium. The urinary findings like dipstick test, heme is positive, 3+ or 4+, pH is acidic, proteins are positive, reddish brown color of urine. Microscopic examination is like myoglobinuria is present, and myoglobin cast and is also present. Coming to diagnostic approach, the clinical suspicion with the history and physical examination, muscle pain, muscle weakness, and tea-colored urine. Then we'll proceed good history taking, history of trauma, exercise, seizure, toxins, endocrine disorders, autoimmune disorder, and recurrent episodes. Then the diagnostic algorithm, diagnostic tests will see for creatinine kinase level at least 5 times the upper limit of normal or 5,000 IU per liter. In urinalysis, dipstick and microscopy for myoglobin, serum creatinine, BUN, electrolytes like potassium phosphate, calcium, uric acid, and bicarbonate. If potassium elevated and calcium is low, this lead to other electrolyte, other cardiac abnormalities. That's why the 12-lead ECG and CBC all are mandatory for that. Additional test only for prognostication, albumin coagulation panel. That treatment is rhabdomyolysis constitutes severe medical emergency that required from diagnosis to life-threatening complications should be avoided. On the etiology is multifactorial, all potential causes the same pathophysiological abnormality which involves increase in intracellular calcium. So we should be aware of all pathogenetic mechanism described above as they are strongly linked to clinical manifestation and lab findings. The most important intervention to limit renal complication is early and aggressive fluid resuscitation. This is the most important. Early fluid and aggressive fluid resuscitation. Delay in initiation of IV fluid therapy is associated with higher frequency of patient requiring renal replacement therapy. The most important is early and aggressive fluid resuscitation. Always there is a debate exists regarding ideal type of volume resuscitation. Alkaline diuresis, it is shown to decrease formation of myoglobin caps and subsequently development of acute kidney injury. But these are mainly in the animal models. And mannitol is also one of the proposed therapy to scavenge free radicals and reduce tissue swelling into osmotic diuretic, so removal of fluid from the damaged muscle cells. Proposed therapies are alkaline diuresis and mannitol, but these treatments not validated in well-defined prospective trials. The retrospective studies have suggested some benefits with addition of mannitol and alkaline diuresis over the normal saline solution alone. The potential risk of volume expansion with bicarbonate-based solutions or mannitol is also there. So this include increased risk of calcium phosphate complex formation and hypocalcemia upon increase in pH. So mainly issues are like the calcium phosphate adduct formation and hypocalcemia, hyperphosphatemia. Hyperosmolar state may occur if mannitol is used instead of impaired kidney function. These are the demerits of mannitol. Obviously, mannitol will lead to hyperosmolality. It is a diuretic. There will be risk of intracellular expansion at first, and mannitol may increase risk of renal failure itself. So in summary, it is like volume expansion, irrespective of type and agent, is most important, and not one is better over other, or not much benefit of mannitol.
Am I audible?
Welcome, Dr. Samir sir, Associate Professor, IMS in some hospital, Bhubaneswar.
Hello.
Sir, please proceed with your talks. Sir, kindly
My
proceed with your talk.
slide is visible.
Yeah,
My slide is
sir, visible
visible.
and your voice is
Visible,
audible. Please
visible.
proceed. Yes, sir, visible. Please proceed.
Okay. So hello everyone. So today I'm going to talk about post cardiac surgery shock. Okay. So also known as the vasovagal syndrome. So again, I'm just want to let you know that I'm teaching you as per means how to write in your exams, or how to in details you have to read by all by yourself. I will just tell the points that you should write in your exams and the structure. So the starting with incidence, okay, around 6%, 3 to 9% is the range. So shock can be cardiogenic or septic only mostly. There can be other causes like pneumothorax and all. We'll see that later, but these are the most common causes of shock post cardiac surgery. Mortality due to cardiogenic shock is around 15%. So when you start the answer in epidemiology, and incidence, you have to write these answers. So early recognition and treatment is crucial in limiting mortality. So most common cause, your cardiopulmonary bypass is the most common cause of the shock because of the reperfusion injury. So definition, there is no consensus on the definition, but there are several definitions available. So few of the definitions: so decrease in cardiac output that leads to hyperperfusion and hypotension with a cardiac index of less than 2 liter per minute per meter square, SBP less than 90 mm, or the need for vasopressors to achieve SBP of greater than 90, and a PCWP of greater than 16 to 18, and oliguria. So this is the definition according to one. And according to AHA, it is a state in which ineffective cardiac output caused by primary cardiac disorder results in clinical and biochemical manifestations of inadequate tissue perfusion. So this shock, another definition says that a shock that occurs within 24 hours of cardiopulmonary bypass in the setting of a cardiac index greater than 2.2. So this was a dicey, I was not sure, but the book has mentioned this cardiac index of greater than 2.2. And SVR, along with that, a systemic vascular resistance of less than 800 dyne second by centimeter to the power of 5. So coming to pathophysiology, it is multifactorial. Obviously, surgical factor, patient factors, both are the three main mechanism that the cause of that is postulated because the cause of post cardiac surgery shock, local surgical damage, reperfusion injury, and the extracorporeal circulation. So coming to the reperfusion syndrome, so there is massive calcium influx, oxidative stress, mitochondrial that free radical generation, mitochondrial permeability, pore dysfunction that leads to myocardial stunning. So myocardial stunning that is poor contractility and there is shock. So the influx of cytoplasmic calcium is generated by the agonism of, this is the basic physiology, G protein copper receptor, okay, alpha 1 and arginine vasopressin and angiotensin 2. So cardiopulmonary bypass leads to dysregulation of this mechanism. Okay, so the catecholamines, the vasopressin and angiotensin, they help in maintaining our BP because of the influx of cytoplasmic calcium. So because this is dysregulated because of the cardiopulmonary bypass, that is again due to your contact coagulation, fibrinolysis, and delayed cellular and humor mechanisms. So hemolysis, because of the extracorporeal blood circulation, there is contact with a foreign body that leads to cytokine release. Hemolysis that leads to cytokine release, IL-1, IL-6, TNF alpha, that again leads to synthesis of nitric oxide synthase, inducible nitric oxide synthase. So increased nitric oxide, and as we know, nitric oxide causes vasodilation. So these cytokines again stimulate the locus coeruleus and the hypothalamic pituitary adrenal axis in the paraventricular nucleus. So that is adrenoreceptor desensitization and a pro-inflammatory state. So this is the basic pathophysiology. This is a pictorial diagram depicting what I told just now. So there is intracellular calcium that is dependent on your that causes your alpha 1, V1, and 81 as I told. So your IL1, okay, my cursor is visible. So IL1, IL6, and TNF alpha increases the down regulates your 81 expression, V1 expression, and alpha 1 expression. So the down regulation, that is vasodilation. Okay, inducible NOS and nitric oxide synthesis. So this is the pictorial description of what I told right now. So as shock persists, there is subsequent depletion of. So as the shock persists, body tries to make more and more of epinephrine, norepinephrine, angiotensin, and vasopressin. So gradual, because of the non-resolving shock, your generally depletion of stores of epinephrine, norepinephrine takes place, and the shock again worsens. So that is why we need your external vasopressors and also hydrocortisone or steroid, which I will again discuss later. Now these were the pathophysiology. In pathophysiology, coming to patient factors. In patient factors, your EF 35%, less than 30% is again with a poor outcome and higher incidence of post-cardiac surgery shock. Prior AC inhibitors, use of dobutamine, milrinone, vasopressors prior to cardiac surgery, patient already in shock prior to cardiac surgery is again a higher predilection for post-cardiac surgery. shock. Diabetes mellitus, insulin resistance, history also is a risk factor. Now, circuit factors, there are length and size of the tube. More the length and more the size, the diameter of the tube, that causes more exposure to the foreign substance, and that is more hemolysis and more your factor TNF and IL-1 IL-6 recruitment, causing more inflammation. And coated and uncoated tube, now there are many coated tubes that make it more physiological for the blood flow outside of the body in the circuit. So they're trying to achieve lesser hemolysis and lesser cytokine release using coated tubes. So coated or uncoated tube can also contribute to your inflammatory status. So coming to management, first is diagnosis, then monitoring. So diagnosis can be based, first there has to be a clinical suspicion that there is a shock. So how do we know when we do monitoring post cardiac surgery, when there is a development of new hypotension, new shock, we can go for various monitors which I will tell now. So cardiac index being less than 2.2, systolic less than 95, MAP less than 65, cold cami skin, mottled skin, central venous oxygen saturation less than 65, higher lactate levels, encephalopathy, lethargy, confusion, reduced urine output, liver dysfunction. These are all, this should raise a suspicion of your post cardiac surgery shock. Okay, so again, so what is my cursor visible? So what we
Yes.
have to assess,
Yes, sir. Visible, sir. Visible.
so what we have to
Cursor is
assess is in a first we have to go for non-device management. First we have to assess whether there is a shock. So what are the reversible causes of shock, like if there is volume status, if it is good or not. Then we should go for hemodynamic monitoring. If there is acidosis present, then clinical indicators, as we discussed, capillary refill time, mottling of skin, cold and clammy skin, capillary refill time, your passive leg rest test, lactates, and all this should be seen. And this is how we monitor whether patient goes into post cardiac surgery shock. Now, so again, a tabulated form, you can write answers in tabulated form rather than sentences, which will fetch you more marks. So you can write point wise, that should be good headings. First history, then clinical assessment, then basic hemodynamic assessment, blood gas analysis, seeing the lactates, PO2, PaCO2 saturation. Okay, so ECG, if there is new onset ischemia, if there is a, then your echocardiography, TT, transthoracic or transesophageal, if there is any pericardial effusion, tamponade effusion. Then laboratory parameters, chest X-ray to see pneumothorax and irreversible causes, non-cardiac causes, pneumothorax, massive pleural effusion, hemothorax, location of tube and lines. So again, then hemodynamic assessment can be done by pulmonary artery catheter or other like PICO, flow track to see cardiac index and others, pulmonary artery occlusive pressure. Okay, so this is how we suspect. Then monitoring, as I told, better to write in tabulated form is better, or you can write point wise. Arterial catheter should be inserted, CVC should be in situ, PAC. Okay, one thing I forgot again, it has to be always ABCD. Okay, so CVC, then your PAC is not your pre-anesthetic but your pulmonary artery catheter. Urine output monitoring, capillary refill time, your ABGs, C for lactates, C for acidosis, if there is organ failure. Transthoracic echo, if possible, can be done for your investigations. Initial treatment should be fluid pressures, inotropes, and prevent and treat. Prevent is most important. Prevent and treat end organ hyperperfusion. Okay, so again a flow chart, rather than writing sentences, giving a flow chart, showing a flow chart will be again better for the examiner. So basic hemodynamic monitoring after post-op, just patient, suppose patient is extubated or whatever. Basic hemodynamic monitoring, assessment of target variables, initial resuscitation. So if target variables achieved, so observation. So what are the target variables? SVO2 more than 65 or SCVO2 greater than 70, MAP more than 75. So okay, these are the parameters. If they have not reached, that is called the post-cardiotomy shock. So go for advanced monitoring like pulmonary artery catheter. So then see if there are any reversible causes like tension, pneumothorax, tamponade, acute valve dysfunction, myocardial ischemia, bystander depression. Okay, then you have to do PSC post that. Now coming to your medical management, that was investigations and yeah, how to diagnose, what to do. Now coming to medical management, first always as I told, ABCDE. Okay, so then you have to see for airway and breathing, then oxygenation, then we have to target for euvolemia. first reversible causes of shock is excluded, then we should target assess the volume status of the patient. Okay, so preload optimization is your first step. So establish your vascular filling, cardiac preload, give crystalloid infusions 5 to 10 ml per kg and may go up to 20 ml per kg. So colloid infusion, as we know that the gelatin, colloid infusion gelatin, they can cause your acute kidney injury. So it is better to go for crystalloids. If you go for colloid, you can go for 5% albumin, but gelatin and all, it causes acute kidney injury. So 6 studies showed that colloid has higher incidence of AK and should be avoided. Safe study, again, albumin versus NS. Although there was no significant difference in the primary outcome, but in the subgroup patient of sepsis, albumin had mortality benefit. So our target should be to maintain perfusion pressure, MAP of 65. If after euvolemia shock still persists, go for vasopressors and inotrope. If a pulmonary artery catheter, we can directly know the cause and we can directly go for vasopressors and inotrope also. So preload is assessed. So again a flow chart just to show. Preload is assessed, low preload, normal or high preload. So if there is low preload fluid and blood products, then if there is high diuresis, or we can go for diuresis or dialysis for ultrafiltrate can be reduced. So if there is vasoplegic shock, we can go for NORAD, hydrocortisone, vasopressin, methylene blue can be given. I will come to that each agent in.
Sabir sir.
What happened?
Just 2 minutes, small interruption.
What happened? I'm talking, it is not audible. Huh? What?
Now it is audible.
Now it is audible, sir. Now it is audible.
Okay, what was the last slide? What was the last slide that was
That
not
flow
audible?
chart.
The flowchart diagram.
Okay. This one, no?
We can't see anything, sir. As of
You have
now.
to share your slide again.
Share again. Okay.
Now we can't see anything. I think we got disconnected.
Now is it visible? Hello?
Yes, sir. Yes, sir.
Visible.
Visible.
So first preload, then your that can be low or that can be normal or that can be high. Accordingly, we have to manage. So assessment of MAP, contractility, vasoplegic shock, we can give drugs. Okay, for contractility, we can give inotropes. So our first was your volume depletion. We have to look after that. Then we have to maintain our MAP, control heart rate and rhythm, improve contractility, increase oxygen transport capacity. So these are our 4 endpoints. So first, control heart rate and rhythm, cardioversion by either if cardioversion is necessary, if there is shock and there is arrhythmia, we can go for cardioversion. If there is bradycardia because the cause of the shock, we can go for pacemaker. Now coming to maintenance of MAP, catecholamines, so NORAD, we can use NORAD. So this is the advantage. Does not increase myocardial oxygen consumption, preserves ventricular arterial coupling, improves cardiac output. So epinephrine and adrenaline, low doses it has mainly beta adrenergic effects, and high doses there is alpha adrenergic effects. Okay, low dose beta, high doses alpha. So that is when your vasoconstriction comes into play in higher doses. If you give only lower doses, there are chances there will be only inotropic effect. There will be no peripheral vasoconstriction. There will be only inotropic effect that can cause arrhythmia and increased oxygen demand. Okay, so you have to use higher doses of adrenaline. So as I told, side effects of adrenaline, arrhythmia, metabolic effects, that can be hyperglycemia, hyperlactates, increased lactates can be because of adrenaline, decrease in splanchnic blood flow, and vasopressin. If the dose of NORAD goes higher, then it can be used. Basically, cardiogenic shock, it acts on the V1A receptors. In cardiogenic shock, there is a chance that it may increase the afterload and cause coronary vasoconstriction that increases the cardiac workload. So if possible, can be avoided, but if it is more than 0.5, we may add vasopressin. Or first we have to start adrenaline, then we may add norepinephrine, then we may add adrenaline rather than vasopressin in case of if it is cardiogenic shock and we have excluded septic shock. Now these are the trial, Wang's trial and VAST trial. So Wang's trial was fewer serious complications than those administered noradrenaline instead of vasopressin, and in VAST trial, so it reduced NORAD dose, but there was no mortality benefit. Whereas the Wang's trial was in cardiac surgery patients, VAST trial was on septic patients. Now, coming methylene blue. Methylene blue prevents vasodilation by inhibiting soluble guanylyl cyclase, okay, and nitric oxide synthase activity. The dose is 2 milligram per kg IV only in first 24 hours. Again, no substantial evidence behind this, but there are observational studies showing the benefits. But there are chances of hemolytic anemia in G6PD deficiency patients and risk of serotonin syndrome in those taking MAO inhibitors. Hydroxycobalamin, unknown, but again it is related to, it also acts as a vasopressor. The mechanism action is related to mostly nitric oxide pathway, though not sure. It is a potent direct inhibitor of nitric oxide as well as nitric oxide synthase. So the side effects again, promaturia, nausea, whatever. Then dose is 5 gram administered by IV infusion over 15 minutes into 1 or 2 doses. If there is no response by the first dose, we can go for 2 second dose after half an hour. Now coming to angiotensin 2, although not available here, but you can write in your answers, direct arterial vasoconstriction by engagement of the AT1 receptor on vascular smooth muscle, stimulation of aldosterone, directly stimulating the adrenal glands to release cortisol, increase ADH secretion, and increase in sympathetic activity. But this is to note that A2, when angiotensin acts on AT1 receptor, this is the mechanism. But when it acts on AT2 receptor, that causes vasodilation as well as inotropy. So again, it depends on the dose that you are using. So after study shows that 3 hours after administration, there is an increase in MAP. Now, how to increase the oxygen carrying capacity? As we know, target hematocrit of 21, we have to target 7, target hemoglobin of 7. If the shock resolves or if there is no worsening of shock, even at hemoglobin level of 7, then you may target a level of 7. Generally, we have been told or we have read that in cardiac patients, because of your oxygen demand, we have to target hemoglobin levels of around 9 or 10. But it says, but this where every study says that we have to avoid any unnecessary transfusions if your patient is there is no worsening of shock even at a hemoglobin of 7 or hematocrit of 21, then we can also target a hemoglobin of 7. Okay. This is the dosing. NORAD, first you have to give NORAD, then vasopressin. If that is not well achieved, you have to go for methylene blue. If again not achieved, we can go for angiotensin 2 or hydroxycobalamin. So if there is high risk of renal failure, so angiotensin. If there is high risk of thrombosis, we can go for hydroxycobalamin. Now coming to the inotropes. So what VAST is over, now inotropes. Now we know NORAD and adrenaline, they also have inotropic effects, and but studies based on the effect as inotropy are very limited. And other agents such as your levosimendan, milrinone, dobutamine, regarding inotropy, there are very limited studies. So these are the various drugs. Those are inotropes. So dobutamine, adrenaline, they improve stroke volume and heart rate. Then your milrinone is a phosphodiesterase 3 inhibitor. levosimendan is a calcium sensitizing inodilator. So other therapies that can be given is vitamin C, hydrocortisone, thiamine. We have known about the Marix regimen, which is used in septic shock. Now, what is the theory? Means what is the reason behind using this vitamin C, hydrocortisone with corticosteroids? They reduce the inflammatory response. First of all, with the corticus trial in septic shock, the suppression of hypothalamic pituitary adrenal axis is observed in your extracorporeal circulation. So, corticosteroids help in that. Now coming to vitamin C and thiamine, they are cofactors in your endogenous amine synthesis, which are used in catecholamine production, and they sensitize the catecholamine receptors. They reduce nitric oxide and lower histamine release. So this is why we use vitamin C higher doses in septic shock patients. There are also studies, few observation studies which show response in cardiac surgeries. So antioxidant properties also counteract your free radicals. Again, that is a method to reduce your shock. But Victas and vitamin TALs, they have, however, not shown any significant benefit. Now, thiamine has been shown to decrease the conversion of ascorbic acid to oxalate, preventing hyperoxaluria, and also it improves clearance of lactate by acting as a cofactor metabolism of lactate by LDH. So that is why your thiamine is also used for shock. Now coming to your, these are all your ionotropy and all vasopressor left hand side. Now coming to the right side failure and pulmonary hypertension that can cause shock. So cardiogenic shock secondary to RV failure has very high mortality. Decreasing the RV load in order to improve your coupling, ventricular arterial coupling, so which favors LV filling. So that can be used. So what must be corrected is hypoxemia, hypercapnia, and acidosis. That the factors that increases your pulmonary vascular resistance and causes right ventricular failure. So these should be corrected: hypoxemia, hypercapnia, and acidosis. Now, local or systemic vasodilators can be tried for this. Systemic causes systemic hypotension, so a shock, patient in shock, the shock worsens. So it is better to use inhaled, which act locally and reduces your pulmonary vascular resistance. So there is inhaled nitric oxide, inhaled milrinone, or inhaled prostacyclins like iloprost, or inhaled prostaglandins also. So these are the inhaled drugs available that can cause local pulmonary vasodilation. Now coming to mechanical, out of the, we have 6% of incidence of post cardiac surgery shock, and out of that 0.03 to 6% develop refractory to medical management. So what are the mechanical devices available that can help in cardiogenic shock post cardiac surgery? One way that everybody knows is IABP, or another extracorporeal like LVAD, or your Impella device, your ECMO. This can be used. So adequate selection of patient, timing of the start of the treatment, training multiple disciplinary team, and we have to know when to use and when not to use is more important. To know when it is not to use, these are the outcome predictors in using mechanical management. So these are the mechanism, and how does it help. The various mechanical options available in front of us: intra-aortic balloon pump, tandem heart, impella, peripheral ECMO, central ECMO, ventricular assist device. So this is the mechanism, what they support, whether the LV, RV, or both biventricular. So how do they support the LV? This is the mechanism. Okay. Then maximum flow and duration, how many days it can be given. This is the table showing that. Now these are the advantages, complications, and contraindications of all the various methods. So these all you have to write. Okay. It is better to make a table and write in short. So advantages and complications and contraindications. Now coming to recommendations regarding how to manage, it is your mechanical support. So it is advisable for support in post cardiac shock. These are 4 class 1 indications that are present. It is advisable for support in post cardiac cardiotomy shock to start before multi-organ dysfunction, okay, or anaerobic metabolism develops. So before there is rise in lactate levels or multi-organ dysfunction, it's better to start support. Okay. So when the possibilities of myocardial function recovery are low, mechanical support is only recommended in patients potentially eligible for heart transplantation. So if there is very low chances of recovery, so unnecessarily do not prolong or do not give mechanical support. It has to be provided only as a bridge to cardiac transplantation. Okay. So early mechanical support is recommended, MCS or mechanical circulatory support. So early MCS is recommended after heart surgery in patients with IABP and optimum medical treatment with failed weaning from bypass. So here also early can be tried. If there is failure to weaning, one or two failures, you can directly go for mechanical support. And in the presence of signs of alveolar distension and stasis, closing of the aortic valve and lung edema, so we can first go for conservative measures like our PEEP and flows, vasodilators, diuresis, and intra-aortic balloon pump, mechanical devices. So the type and mode of mechanical circulatory, uni or biventricular failure, right or left side failure, post in pre, intra or post, if it is present pre or prior, or it is developed after surgery. Then ECMO with peripheral cannulation should be considered in patients with post-cardiectomy shock in the presence of alveolar biventricular dysfunction. Then if there is isolated RV failure, we can go for oxy-RVAD. Okay, ventricular assist device, only the right ventricular assist device. Now, short-term use of ventricular assist device in patient with isolated RV dysfunction may be considered as the first treatment option. These are all class 2 indications of using mechanical circulatory support. In the presence of structural alterations of the heart, so instead of this, we should opt for intra-aortic balloon pump. It may be considered in cases of moderate ventricular dysfunction during weaning, and maybe okay. Then severe cases directly go for mechanical circulatory support. Moderate cases you may try IABP before going to your mechanical support. In severe LV dysfunction, do not go for IABP. Directly go for other mechanical supports like ECMO and all. So this is a overview of the drugs, mechanism of action, and the dose. So again, a summary of how to manage: optimization of preload, optimization of rhythm and heart rate, optimization of ventricular arterial coupling by inotropes or inodilators, optimization of perfusion pressure, use of vasoactive drugs. Okay, so for ventricular arterial coupling, we can see that if failure of drugs, we can go for mechanical support. Okay, and the indications I have told, which are class 1, which are class 2. Severe, go for mechanical support. If there is mild to moderate, you can go for other intra-aortic balloon pump, or you can try drugs. If there is refractory to medical treatment, then you may go for mechanical support. So optimization of perfusion pressure by your vasopressors, optimization of respiratory function. If there is LV failure and pulmonary edema, we can go for application of PEEP, Abbott atelectasis, normal Abbott hypercapnia or hypoxemia and metabolic acidosis. So refractory situations, you may go for mechanical, that is ECMO. So renal support, you are now coming to ancillary support. Renal support, if there is septic shock we are suspecting, we have to give antibiotics. Then renal support, if there is reduced urine output because of your poor LVF, poor LV fraction, poor, there is poor renal circulation, then we can that can be reduced urine output. We have to monitor the acidosis, monitor the lactate levels, and we may plan for RRT. Best method in severe shock is obviously your continuous renal replacement therapy. So it is noted that 65% of these shock patients require RRT because there is hypoperfusion of the renal system. So 10% eventually do not recover and may need lifelong renal support. There is no evidence to suggest that early start of RRT reduces mortality. Now respiratory support, mechanical ventilation, or you may go for ECMO, target oxygen exchange of 90 and PO2 60. Thank you.
That's very nice presentation, sir. Samir sir. It's very nice presentation.
Thank you.
Sir, there is small query from my side actually. So coming to your first slide, you mentioned about the vasoplegic syndrome. So the drug of choice of vasoplegic syndrome is methylene blue. Usually we will be using methylene blue in vasodilatory conditions and vasoplegic syndrome like vasoplegic syndromes actually. What is the role of methylene blue in sepsis patient? Is there any evidence basing on that, sir? Methylene blue in sepsis patient.
No, means in sepsis particularly there are no randomized trials that for because of which we can bring it into the our treatment regimen. Even if you're going to try it in septic shock patients, you have to go, means it has to be done under trials.
Okay, sir. Okay. Sure, sir. Nice, sir. Thank you. Without any delay, I want to welcome Dr. Rupali Patnaik, Associate Professor of IMS and Some Hospital, Department of Critical Care Medicine, to talk about approach of clinical approach of patient with shock. Rupali, ma'am, please kindly share your screen, and off to you, ma'am. Samir, sir, you can unshare your screen. Rupali, ma'am, kindly start your presentation.
Yeah.
Yeah,
Okay,
please.
I'll be talking on clinical approach to shock.
Yes, ma'am.
Shock is clinical expression of circulatory failure that lead to cellular or tissue hypoxia that lead to reduced oxygen delivery, increased oxygen consumption, and inadequate oxygen utilization. These are the three main abnormality which is results due to cellular or tissue hypoxia in shock. Shock affects almost 1/3 of patients in ICU with various pathophysiologic abnormality in clinical, hemodynamic, and biochemical signs symptoms manifest with patients with shock. Coming to hemodynamic manifestation, they have systolic blood pressure less than 90 mmHg or MAP less than 65 with vasopressor need. These may be absent in early shock or chronic hypertension. Features can be tachycardia with early compensatory features, which can be missed with previous use of beta blockers or tachypnea. The Q SOFA is the early identifier. Then inadequate tissue perfusion, it leads to oliguria, altered mentation, and hypoperfusion features and cold clammy skin. Then biochemical parameters like hyperlactatemia, usual cutoff is more than 2 millimoles per liter. The blood lactate in septic shock is prognostic and predictive value. It is independent of clinical signs of organ dysfunction in patients with severe sepsis and cardiogenic shock. It's a prognostic indicator also, hyperlactatemia. Then hyperlactatemia due to abnormal metabolism and both aerobic and anaerobic. Anaerobic is like oxygen imbalance, regional microcirculatory imbalance, and aerobic increase aerobic glycolysis in sepsis, mitochondrial dysfunction, liver dysfunction, and increase pyruvate dehydrogenase activity. Okay? The increased glycolysis that leads to hyperlactatemia. The pathophysiological mechanisms are basically different depending on the types of shock. The types of shock can be hypovolemic, cardiogenic, and obstructive, and other is distributive. In hypovolemic shock, cardiogenic shock, and obstructive shock, mainly low cardiac output state and inadequate oxygen transport. Whereas in distributive shock, okay, this decreased systemic vascular resistance, distributive shock is like sepsis shock, and altered oxygen extraction. The various combinations in acute circulatory failure. The types of shock is mainly most common, is distributive shock, which is septic variant, 62%. Others contribute to like cardiogenic shock of 16%, followed and hypovolemic shock, same. And obstructive and distributive shock is less. The distributive other like non-septic variant of distributive and obstructive shock. This is the types of shock. Epidemiology, septic shock is most severe form. Mortality rate ranges from 40 to 50%. Most common is the septic shock, followed by cardiogenic and hypovolemic. Cardiogenic shock is mainly most common after acute myocardial infarction, 6 to 9%, and with increased hospital fatality rate. In cardiogenic shock is increased mortality rate compared to septic shock. Then distributive shock. Distributive shock is sepsis. One is septic variant. Septic shock is the subset of sepsis in which underlying circulatory and cellular or metabolic abnormality is profound enough to substantially increase the mortality. Sepsis is like this life-threatening organ dysfunction caused by dysregulated host response to infection. The septic shock is the subset of sepsis in which there is underlying circulatory and cellular or metabolic abnormalities that is profound enough to substantially increase the mortality. The clinical construct is persisting hypertension requiring vasopressor and fluid therapy to maintain mean arterial pressure more than 65 and serum lactate level more than 2 millimoles per liter. This is the objective criteria for sepsis. septic shock. The distributive shock of non-septic variants can be inflammatory like SIRS in bone, trauma, pancreatitis, post-cardiac coronary bypass, and post-cardiac arrest. Neurogenic shock like spinal or traumatic brain injury, anaphylactic shock, other like drugs and toxin-induced, and endocrine causes like adrenal crisis and myxedema coma. These are the non-septic variant of the distributive shock. Then comes the cardiogenic shock. Cardiogenic shock can be cardiomyopathies due to myocardial infarction, severe right ventricular infarction, acute and chronic heart failure, and stone myocardium like cardiac arrest, hypotension, or cardiopulmonary bypass. And even in advanced septic shock, there is cardiomyopathies, sepsis-induced cardiomyopathies, and myocarditis. These are the cardiomyopathic causes of cardiogenic shock. There can be arrhythmogenic causes like tachyarrhythmias or bradyarrhythmias that lead to cardiogenic shock. Or can be mechanical abnormalities like severe aortic or mitral valve insufficiency, acute valvular rupture, aortic stenosis, ventricular septal wall defense, ruptured ventricular wall aneurysm, or atrial myxoma. These are the mechanical causes which lead to cardiogenic shock. Then comes the hypovolemic shock. Hypovolemic shock can be hemorrhagic variant or non-hemorrhagic variant. Hemorrhagic causes are like trauma, GI bleed due to varices bleeding or peptic ulcer induced bleeding, intraoperative or postoperative bleeding, hemorrhagic pancreatitis, postpartum hemorrhage. These are the hemorrhagic causes of hypovolemic shock. Non-hemorrhagic causes can be due to losses. Losses can be through GI loss, example diarrhea, vomiting, external drainage due to presence of drains in the GI tract, and skin losses like heat stroke, burns, traumatological conditions. Renal losses can be excessive drug-induced diuresis or osmotic diuresis, salt-wasting nephropathy, and hypoaldosteronism. There can be third space losses like in trauma, intestinal obstruction, cross injuries, pancreatitis, and even cirrhosis, which are the causes of hypovolemic shock. Then hypovolemic shock, hemorrhagic is mainly the classification of hemorrhage based on the loss of blood volume, 15%, 15 to 30, 30 to 40%, and more than 40% of total blood volume loss is the classification grade of the hemorrhagic shock. The type 4 is the most severe variant. By type 3 onward, the decrease in blood pressure and like decrease in urine output. Then obstructive shock. Obstructive cause can be pulmonary vascular causes or mechanical causes. The pulmonary vascular causes can be pulmonary embolism, severe pulmonary hypertension, severe or acute obstruction of the pulmonary or tricuspid valve, air embolism, fat embolism, amniotic fluid embolism. These are the causes of pulmonary vascular obstruction leading to obstructive shock. Other mechanical causes can be tension, pneumothorax, pericardial tamponade, constrictive pericarditis, and restrictive cardiomyopathy. These are the main important causes of the obstructive shock. Okay? The pulmonary vascular causes and other mechanical causes. Then what is important is the phase and focus. The main is the focus on salvage, first initial resuscitation, then optimize, stabilize, then de-escalate. Okay? That is provide appropriate support, then optimization and stabilization phase, then we think for the weaning from the fluid or vasopressor agents. Along with the clinical examination, what is most important is the use of ultrasound. Ultrasound is point of care ultrasonography focus for the initial in hemodynamic assessment. The Ross exam sequencing. Ross is rapid ultrasonography assessment for hemodynamic instability. Basically, it is various views we have to see. The parasternal long, these are the various views I have seen. Parasternal long axis cardiac view, apical 4-chamber cardiac view, and IVC view here, the Morrison pouch hemothorax view, the splenorenal hemothorax view, the bladder view, and aortic views. These are abdominal aortic aneurysm, and the pneumothorax views. The 8 and 9 are the pneumothorax view. All of here you use the curvilinear probe, but for pneumothorax assessment, better to use the high frequency probe. So this is ultrasonography examination should go hand in hand with the physical history and physical examination, so that should not lose anything or miss anything for him diagnosing the appropriate shock, so that the management itself is prompt. This is the RUS protocol evaluation. We have to assess by pump, tank, and pipe approach. Okay, the pump, tank, and pipe, how it varies with the type of shock. In the hypovolumic shock, the pump is the heart physically. Hypovolumic shock, heart is hypercontractile heart, with small chamber size. There is volume loss or hemorrhage that are the causes of hypovolumic shock. In cardiogenic shock, the pump is hypercontractile. Like cardiogenic shock, the heart is not contracting, it is dilated. In obstructive shock, like in it is either hypercontractile heart or pericardial effusion in cardiac tamponade, or if there is pulmonary embolism or cardiac thrombus that lead to RV strain. Okay? And hypercontractile heart, then other causes like distributive shock. Distributive shock is sepsis in hypercontractile in early phase, or it is sepsis into cardiomyopathies in late stage lead to hypocontractile heart. This is the pump, how it varies in the different variants of shock. Then after pump, we'll evaluate for the tanks. Okay, the tanks are the pipes which are tanks are the those who are connecting the pumps to the pipes. Okay, these are, we have to assess the IVC. In hypovolumic shock, the IVC is flat, or it is variant IVC, or flat jugular veins. There is peritoneal fluid in fluid loss, or if there is hemorrhagic shock, then obviously in the tanks, like there in the Morrison's pouch or hepatorenal or splenorenal pouch, there will be fluid accumulation. Then in cardiogenic shock, IVG is distended. Here it is collapsible or flat IVC, it is distended IVC in cardiogenic. And distended JBP, jugular veins also. In pulmonary edema, long rockets, like it is overloaded tanks, that is leads to increased B lines, and pleural fluid, peritoneal fluid in ascites, and pleural fluid in pleural effusion. In obstructive shock, the IVC is distended and distended JPP, that is absent long sliding in pneumothorax, which I'll go to the figures later on. And distributive shock is normal or small IVC in early sepsis. In peritoneal fluid is something source of sepsis, pleural or peritoneal fluid, then these are the abnormality with these tanks. Then pipes is mainly abdominal aortic aneurysm or dissection. This is lead to abnormality in these pipes. In cardiogenic shock, the pipe is normal. In obstructive shock, due to pulmonary embolism, and the pipes can be that there is presence of thrombosis, that is the cause of pulmonary embolism or obstructive shock, and it is normal in sepsis and cardiogenic shock, the pipes. Okay, I'll go in detail. This first comes to evaluation of the pumps. There are the view, parasternal long axis view, the apical four chamber view, and the subgifford view. Okay, this is the subgifford view in patients with cardiomyopathy, enlarged heart. See how the chambers are enlarged, and it is seen in the subgifford view. Then coming to evaluation of the pumps for the large pericardial effusion leading to tamponade. Here is the pericardial effusion, tamponade leading to RV diastolic collapse. Here the RV is being collapsed in diastole. Then evaluation of pump in the cardiac tamponade, subgifford view. Okay, this way, below the liver there is accumulation of the pericardial fluid leading to RV collapse. Then RV strain, parasternal long view in the RV strain, basically in the either pulmonary embolism or cardiac thrombus that lead to strain in the RV leading to obstructive shock. Then evaluation of the pump for the thrombus in the RA, floating thrombus in the right atrium, okay, that leads to obstructive shock. After pumps, we'll evaluate for the tanks. Okay, the tanks, the views are for IVC view. Here, the right upper quadrant view for the pleural view, and the left upper quadrant view. Okay, right and left upper quadrant views, and this the IVC view, the first pelvis view. Okay, first basically include the pelvic view, and these are the views which is extended above 2C for the presence of any pleural effusion or hemothorax. Okay, this is fast. And pneumothorax and pulmonary edema, this is the view. This is the evaluation of the tanks. And the IVC, low cardiac filling pressures. So it is like IVC is collapsible in the hypovolemic shock, or in hemorrhagic shock. In hypovolemic shock, it is collapsible. Then IVC is like SNP stress. It is collapsible IVC in the hypovolemic shock. Then high cardiac filling pressures, like in patients with like cardiogenic shock or in obstructive shock due to pulmonary thromboembolism due to dilated IVCs. Then comes the evaluation of the tanks. Tanks in the, it is like a hepatorenal or Morrison's pouch, presence of fluid, right? Pleural effusion. The splenorenal hepatorenal pouch will think for the presence of accumulation of the fluid, and in the pleural effusion or hemothorax. Then tanks are compromised is very much alarming. In fact, one is most important is the pneumothorax. The normal lung here in the M mode, there is no motion of the lungs, in the no gestural motion. It is positive motion or seesaw sign, and brain is ever. This is the M mode. In the pneumothorax, it is the barcode sign, no gestural motion. And presence of B lines with long edema, presence of multiple B lines are there in fluid overload state. Then after pump, tank, then comes the pipes. Pipes, we see the suprasternal and parasternal aortic and epigastric. These are the supraumbilical or the aortic views for presence of aortic aneurysm and aortic dissection. And the DVTs to present if the suspected causes for pulmonary thromboembolism, which is the important cause for obstructive shock. This abdominal aortic aneurysm, okay, it is dilated and the size is more than basically 5 centimeter, then it is dilated. And the intimal flap is present, then it is dissection, dilated aorta with intimal flap here inside the aortic dissection. The clogging of the pipes, obviously, with the clots, thrombus, that is the important causes of pulmonary embolism, one of the causes to evaluate for obstructive shock. Because the point of care ultrasound group has significantly less total time on vasoactive agents and transfer improve outcome. Along with history clinical examination and approach, the point of care ultrasound needs aid on to the prompt diagnosis and treatment also early. It has potential to optimize care in critical ill patients when added to clinical administration of the intensive care physician. Then comes the microcirculation, also important cause for the shock, the microcirculatory dysfunction. It is not going into detail. It is various parameters are there to assess the microcirculation. Obviously, microcirculatory blood flow is reduced, that lead to and oxygen consumption, oxygen content, which is the important for oxygen distribution basically, and the oxygen uptake is defective in the microcirculatory dysfunction of the shock. There are hemodynamic variables in various shock states. Okay. Like hypovolemic shock, increased cardiac output, the systemic vascular resistance is increased, mean arterial pressure is low, and pulmonary arterial bed pressure is low, CBP is low in hypovolemic and hemorrhagic shock. Like in cardiogenic shock, cardiac output is low, SVR is high, and pulmonary arterial bed pressure is increased, and CBP increase in cardiac shock. Obstructive shock, cardiac output is low, SVR is high, pulmonary arterial bed pressure is high, and CBP is high. Distributive shock, like sepsis shock, the cardiac output is high in early and late it is decreased, SVR is less, right? And your pulmonary arterial bed pressure is normal to decrease, or CBP is normal to decrease. Okay. Main difference is in the cardiogenic and obstructive shock, the pulmonary arterial bed pressure, CBP, everything is elevated, SVR is elevated, and cardiac output is low. However, it is hypovolemic and an early septic shock, the cardiac output is high. Is here in early septic shock, the SVR is low, but is hypovolemic shock, it is very much elevated. Then the ultrasound findings, okay, obviously I have all told all in detail, not going in detail again. These are the various protocols they used to see the imaging profile in shock states. Okay, some cases, okay. The 51 male with hypertension CAD present with shortness of breath, chest pain and cough for 1 week. It's now worsened. No fever history, although he often has been sweating at night. On arrival to ED, he is agitated, confused, pulling off his oxygen mask. Vitals are heart rate 94 per minute. Blood pressure is low, 80/60 on NIBP, and saturation is only 76% on room air. Respiratory rate is high. Temperature 96.4 Fahrenheit. Focus examination ED suggested plaques cardiac view indicating severe hypodynamic function. Last plethoric IVC without respiratory variations with B lines present in the long field indicating interstitial fluid. So likely cause of shock here is the cardiogenic shock basically. Okay. This is the parameter, and the focus examination is add on to it. It is the likely cause of shock is the cardiogenic shock. Another case, patient 63-year female with comorbidities, prenatal ED from nursing home facility she is staying with altered mentation. For nursing staff, she had been more lethargic recently and today was noted to be more confused than usual. She reported chronic cough which is worsened. At admission vitals to our hospital ED, heart rate is 110, blood pressure is 60/40, saturation is 88%, and respiratory is 20, and temperature is 95. The focus examination suggested parasternal short axis cardiac view indicating hyperdynamic function, flat collapsible IVC with significant respiratory variation. Obviously, she is hypovolemic. Extended right upper quadrant view shows right hemithorax with complex effusion. The likely cause of shock here. She is already chronic nursing home stay with recently not that much well from before, and this much is the hemodynamic parameters and the suggestive of this. This is likely cause here is the septic shock. This is complex effusion, can be empyema or something, pneumonia that complicated empyema, and she is very much fluid responsive initially with collapsible IVC. This landed up in septic shock to RED. The third case is 64-year female with comorbidities and prior CABG also present with chest pain and shortness of breath for the last 4 hours. Reports she report onset of pressure like substernal chest pain, and it's continued to increase in severity and now associated with shortness of breath. Symptoms have been worse with exertion, not improved with aspirin or anti at home, mild nauseating, and she had a dry cough associated with her symptoms. Unsure if she had fever also. The vitals is like 120 is heart rate, blood pressure 90/40, saturation 94% room air, and temperature she is febrile. And the focus examination suggested parasternal short axis view indicating hypodynamic function in large RV. Apical 4-chamber view confirmed RV-LV ratio more than 1. Large plethoric IVC and non-compressibility of the femoral vein indicating DVT. So likely cause of shock here is the obstructive shock due to pulmonary thromboembolism. Could be this is the DVT is the source that led to pulmonary thromboembolism. RV is large and hyperdynamic function, and RV-LV ratio is high. Okay, not going into detail. Already Dr. Abhilash has told all this. This is features of pulmonary thromboembolism, and IVC is plethoric. This is important cause of obstructive shock. Then 18-year male suffered RT with polytrauma, present to ED with altered mentation, chest and abdominal pain, and difficulty in breathing. And vitals is tachycardic, blood pressure is low, tachypneic, saturation is low, and GCS is also octant reduced. Like focus examination suggested eat fast, like extended fast examination. Fluid collection at the right upper quadrant. Morrison pulse fluid collection, and also there is ups and long sliding with long point on the left side. Long point is more specific for pneumothorax. The possible causes of shock here can be, it is like tension pneumothorax could be there. Okay, the polytrauma patient, not single cause can be the tension pneumothorax refracture that lead to absence of long sliding pneumothorax, and this is the cause of obstructive shock, or it can be fluid collection at the right upper quadrant pouch, or that can be hemorrhagic trauma to abdomen leading to hemorrhagic and obstructive, both components in the polytrauma patients. Thank you.
That's a very good presentation, ma'am.
Thank you, Chandramouli.
And this presentation has given an overall view that the role of ultrasonography and point of ultrasonography in the ICU basically. Yes, ma'am. And without any delay, I want to welcome Dr. Abhilash Das, Associate Professor of IMS in some hospital, to tell about the data interpretation in ECG. Sir, Abhilash sir, kindly share your PPT. Sir. Ma'am, unshare your PPT. Ma'am.
Yeah, I am saying that.
Okay, ma'am. Abhilash sir, kindly share your PPT.
They're not able to see.
We can able to hear you, sir. We can't able to see anything else.
Okay, wait. Now,
Yeah, we can able to see. We can see, sir. We can proceed. We request participants to post answers in the chat box. So it is interactive session basically. Today we are dealing about ECGs. Please, sir, please continue.
So this is a ECG, 12 lead. There is a abnormality. Anyone can tell what is the abnormality? Whether any participant left or
No,
everyone?
somebody has posted prolonged PR intervals.
Arey, where is the chat box? Okay.
I will be seeing chat box for you.
Yeah.
Somebody has posted prolonged PR.
PR interval. So this is type
They
1.
want to say something
type
about
2.
block. Type 1.
This is type 1 or first degree heart block.
First degree heart block, yeah.
Then what are the conditions? Normal variant also can occur. Influval AMI,
Yeah.
digital toxicity, myocarditis. Okay. Then how will you diagnose? PR interval more than 0.2. Here it is 0.3 seconds.
0.32.
Then normal QRS, normal QT, other morphology is normal. Okay. Any doubt?
No, sir, as of now. You can proceed to the next slide.
Next. So it is first degree heart block. So see this. This ECG is showing something. What is it? This typical. This is called J wave or Osborne wave. Where it is found?
Any answers from the participants? Somebody is saying hypothermia, sir.
Yeah. Thanks. It's the correct answer. So what is your management?
Management of hypothermia, active warming, what it is.
Unmute people. Active warming by using warmed air blanket, IV fluids, humidified oxygen.
Exactly. Yeah, that's what they answered actually. Both passive and active warming. Dewarming.
These are the J waves as tall as QRS. Okay. The height corresponds with the severity. Okay.
Yes, sir.
This.
Usually compared with the R wave. Yeah.
Compared with QRS, this is wide and tall also. Wide and QT, QRS complex, wide and QRS complex. Okay. Then PR interval is also prolonged. So all these will lead to asystole. Hypothermia is a reversible cause of cardiac
arrest. Yeah. Yes.
So what is this ECG showing?
Can anybody answer the ECG?
Definitely tachycardia. Whether it is ventricular or supraventricular.
Narrow complex tachycardia.
Narrow complex means
Supraventricular.
origin is supraventricular because less than 120. Okay, so supraventricular tachycardia. Okay.
Yes, sir.
What is the management?
For adenosine, beta blockers, cardioversion.
According to patient's clinical condition. Whether with this tachycardia he is hypotensive or normotensive. If hypotensive, then
cardioversion. Electric cardioversion.
How much joules? You start
how many joules?
You start from 50 joules and
50 to 120.
Synchronous cardioversion, if hypotensive or cardiac ischemia, heart failure, you start from 50 and increase if there is failure. If patient is not hypotensive, then you can start with vagal maneuvers like carotid massage, cold water immersion of face, Valsalva. Then drugs like adenosine, verapamil can be used. Adenosine, first you give 6 milligram. Then you see the response. If there is no response, again you have to give 12 milligram increment, total doubling of the dose of adenosine. Okay. Alternatively, you can give beta blockers like metoprolol, propranolol also. So the rate is around 180 definitely it is not atrial flutter, because flutter rhythm is at will be around 150 or 300, and there is no visible P wave. So definitely it is not originating from the SA node. Even if it is supraventricular, it is not from SA node. AV nodal reentrant. Okay, AV NRT type of supraventricular tachycardia. Okay. So what is this ECG?
Torsades.
Yeah, torsades.
Somebody saying QDP, sir. Torsade depointers.
Torsade is depointers. So sequence of events in this rhythm strip. This is starting from this. This is typical torsades. Polymorphic VT. Okay. Then continuing. Then abrupt cessation of torsades to sinus rhythm. So what will you see further in this ECG? Once you get normal, then you can look for QT prolongation, because QT prolongation occurs in torsades, and QT prolongation will lead to also torsades. Okay. So diagnosis is VPC. Initially there is VPC, and then one sinus rhythm, again VPC, that is converting to torsades. Okay. Different morphology, height is also different, and width is also different. Then there is spontaneous reversal without any extra spike, means it is not done by defibrillation. Something spontaneous, or some IV drugs have been given. Drug of choice, magnesium
sulfate.
Okay.
Magnesium sulfate.
Magnesium sulfate. If you find a electrical activity, that is peaked electrical activity, mostly that is defibrillation. Okay. After defibrillation also, you can do means that sinus rhythm can be achieved. So two things: one is defibrillation, one is magnesium. Okay. So you will look for prolonged QT interval post reversion ECG. Okay. Then any diagnosis in this ECG?
Inferior wall myocardial infarction.
Inferior wall STEMI.
Look at 2, 3, AVF, V1, sorry, V2, V3. So ST segment elevation, AMI of inferior and posterior. Why inferior and posterior? Inferior is 2, 3 AVF, 1, 2 can be anterior, can be posterior. Okay. So it is inferior posterior acute myocardial infarction with Mobis type 1 block. Whenever you find any inferior wall AMI, you have to see for three things. What are the three things? One is heart block, one is right ventricular AMI, one is posterior wall AMI. Okay. Any inferior wall AMI means any ST segment changes in lead 2, 3 AVF. You search for any AV block, maybe prime first, maybe second degree, maybe complete heart block. Then you find for posterior wall AMI. Okay. Where you will find posterior wall AMI?
Right side leads.
Posterior wall AMI, for that you have to attach V7 to V9 leads. Okay. From V6, you will continue V7, V8, V9, the posterior part of the chest. And typical ST segment elevation of V7 to V9 leads will come from a posterior wall AMI. And for right ventricular AMI, how will you see? You can see in the V4 right. Same location, V4, V5, V6, just mirror image of the left. So from V4 to V1 to V6, right-sided leads. If there are changes, definitely there is right ventricular AMI. Okay. So significant ST elevation with hyperacute T changes in the inferior leads, ST depression with inverted T waves in the posterior in the V2, V3 leading posterior AMI, and rhythm strip demonstrate PR interval prolongation, and until a P wave fails, means gradual prolongation of PR interval till there is a total non-conductance of the P wave. That is secondary heart block with that is type 1 of second degree Winkeback. So what is this ECG? See the P waves and QRS and their relation.
Complete heart block.
Yeah, good.
AV dissociation.
Because at regular intervals, this strip is having P waves but there is no relationship with the QRS. Lot of P waves, few QRS, so it is complete heart block. What physiological disturbance you will find? You can anticipate it after this heart block. Hypotension, okay, leading to cardiovascular collapse. And what is the definitive intervention?
Pacing.
Pacing, temporary or permanent. Okay, so diagnosis is complete heart block, hypotension leading to cardiovascular collapse, permanent pacemaker. Initially, you will go for temporary pacemaker, and definitely you have to finally give a permanent pacemaker for this patient. So normal PUA morphology and intermittent occurrence of the QRS, the ventricle rate is 50. So it is not SA node. It is not coming from SA node. It is junctional. Okay. No evidence of infraval ischemic event. So any heart block also you will see for infraval ischemia. As I told, any infraval MI you see for heart block. Any heart block patient you see for infraval ischemia. This is reciprocal. Okay. So what is this? 2, 3, V2, V3. STEMI? Huh?
Anterior valve STEMI.
Anterior valve MI. So it is anteroseptal anterior valve MI. Okay. So what is the management? Initial management? You see the vitals, ABCD approach. Maintain hemodynamics, airway, breathing, circulation. Then definitive.
Depending on the time percentage.
Thrombolysis. If patient coming within 30 minutes, thrombolysis. Door to needle time. And if patient is coming within 1 hour, PCI. Okay. PCI 60 minutes. Door to balloon time. PCI. If patient coming within 12 hours, door to balloon time is 90 minutes. Okay. 60 minutes, 90 minutes. You remember these golden periods. 30 minutes for thrombolysis, 60 minutes for initial PCI, and if patient comes a bit later, then 90 minutes. Door to balloon.
Please.
Okay. So what are supportive measures like MONA? MONA means morphine,
oxygen, nitrates.
sublingual nitrates. Then you go for anticoagulation with IV heparin or IV fondaparinux or IV Clexane or low molecular heparin. Target APTT is around 60 to 90 seconds. Beta blocker for rhythm control. Okay. And if patient with infraval MI, will you give this morphine, this nitrate and all with hypotension? We have to avoid. Okay. And later on, you will start myocardial remodeling agents like ACE inhibitors, beta blockers. Okay. So another thing, if you see in lead 2 and lead 3, definitely you have to search what is the vessel. Okay. It is left anterior descending. That is proximal part. Because if the lateral region is unaffected, suggesting that circumflex has been spared. Lateral means V4, V5, V6. If only V2, V3, V4, V5, V6 is not affected, then anterior part of left anterior descending. Okay, proximal part. If V4, V5, V6, then you can see that circumflex has been blocked. So that left main artery will be blocked. Okay. Recognizing the artery involved is also very important in AMI. Okay. So this ECG, last ECG for today. Showing, what is this? T, tall T, widened QRS,
hyperkalemia.
Sine wave appearance, hyperkalemia.
Just going into sine wave appearance, just before sine wave is totally like this, sinusoidal. It is just before the sinusoidal part has been, will be coming. Before that, absence of P, wide QRS and tall T, hyperkalemia. Okay. See, this is management.
Antikalemic measures.
Like
glucose insulin, calcium gluconate, glucose insulin drip, K-bind sachet, acetylene nebulization.
Mechanism of action. Quick. Calcium gluconate
for stabilization of membrane.
If there is no ECG changes, will you give calcium gluconate?
No.
No.
Not indicated.
Yeah. Then anti-hyperkalemic, this is membrane stabilizer. Calcium gluconate or calcium chloride, whatever you want. Then Anti-hyperkalemic
Then
things.
glucose insulin drip.
Glucose insulin drip. Then any other thing?
Astelline
Astelline
nebulization.
nebulization.
These will all, and sodium bicarbonate. These will all shift the potassium to intracellular things.
Intracellular.
Next, definitive management.
Diuretics or dialysis.
Yeah, diuretics like furosemide that will remove the potassium, extracellular potassium, and finally, resistant hyperkalemia, not amenable to any therapy, go for dialysis. Hemodialysis is the choice. Okay. So calcium chloride or calcium gluconate, membrane stimulation. Okay. Sodium bicarbonate will prevent acidosis and promote potassium shift to intracellular area. Then dextrose with insulin that will stimulate more insulin release that will lead to intracellular potassium shift. The time period is also very important. And then salbutamol nebulization or astelline nebulization, intracellular shift, loop diuretics like furosemide, polystyrene sulfonate take bit more time and gradual removal of the potassium from GI tract. Okay, definitive is dialysis. Okay, everyone clear with all 7 ECGs? Anyone having any doubt?
No.
These things come to ICU. That's why I've given these ECGs. Okay. That's all for today. We'll start tomorrow at sharp at 4 p.m. Thank you.
Yes, sir.
Good night.
Okay.
Good
Thank
night.
you.
Good night, everybody. So this is the end of the session, and tomorrow's session will be started by 4 p.m. in the evening.